Anybody else? Okay. Will you agree that we are trying to overcome some of the disadvantages of a traditional lecture? Would you like to agree? Very good. Thank you. So the purpose of innovative teaching learning method is to overcome some of the disadvantages of the traditional teaching methods. So with that short introduction, I'll start my presentation. So the objectives of this session objectives are I've given you a handout, okay? If you see there is a handout on innovative TLMs in your, I'm sure you have it with you. How many of you have it? Good, thank you. So that you have to learn to enumerate. Then we'll see how to incorporate them into the existing curriculum. Is it a very big issue? Is it possible? Is it possible to incorporate these innovatives in our lectures or practicals, clinics, and to identify methods of overcoming time constraints? Time is limited. You can't make 8 to 4 into 10, no. Time is limited. But we have to do these things according to our. So the context of this presentation is the NMC has made a curriculum change and they have included some new terminologies there like learner-centric from teacher-centric, outcome-oriented, global to conform to global trends. The student should be able to collect, analyze, communicate health data appropriately. You should have to give them practices in problem solving. They should be able to interpret and integrate data, also meaning different departments. They should learn to apply their facts. So many things, words they have added. And we have also to make them into a self-directed learner. So many words are there. How do we do it? In short, when we prepare for a teaching session, whichever teaching session, lectures or practicals or clinics or integrated teaching, we have to also focus on the process apart from the content in which you are an expert. So the talk is mainly going to be the process of delivering what our subject expert is. The process of delivering our subject expertise. This is a famous saying by Yeats. Education is not filling a bucket, but it's about lighting the fire. Yesterday we saw this fire in our student, final MBBS students. He was standing here. He showed how much fire it is there inside him. Fire is there. It's smoldering. We have to ignite it. Motivate them. Make them do many things so that their talents become evident. They learn more. So our duty is to light the fire. Some buckets we have to fill, but not all buckets, because buckets keep on increasing. So many diseases, new concepts, new treatment. How you are going to tell everything? Not possible. So we have to aim at lighting the fire Of course, some buckets we have to fill. Can you name some innovative TLMs you have already heard or used? Can you name some? Yes? Any innovative TLMs you have heard of? I think Dr. Sanjeev talked about it yesterday. Any names?
Team-based learning and inquiry-based learning.
Team-based learning, inquiry-based, yes. Self-directed learning, which is a method for making a student lifelong learners. Yes, any other?
Game-based learning.
Some of you attended one workshop yesterday. What was the name? Problem-based learning. So all these are, any other? Flipped classroom, yes, very good, thank you. So all of you are aware of some of these names, and the method that I have used to elicit them is called brainstorming. So brainstorming is a method of eliciting prior knowledge so that we can build up on that in the student. So in the class you will be asking about subject. So these are names of some of the innovative TLMs. You can go through your handouts and there will be a short description of all these methods. Think, pair and share. You ask the students to think first, then pair and share what you have understood, and then share with the larger audience. Buzz group, a little larger group, there's little noise there. Muddy points. Muddy points means eliciting what they don't know. And I'll show you a method sometime later. Brainstorming we did just now. Rounds. Rounds is when you go near one particular student and ask him a particular question. Going rounds. So you may have identified some students who are sleeping or playing with something or not attentive or a good student. You want a good answer. So that is rounds. You go near them. Only thing is you should ask only yes or no questions because they will be scared. The moment teacher comes near, they get scared. And whatever they know also they will forget. That is rounds. Then concept map also yesterday I saw Dr. showing a concept map. I'll show you one at the end. Flipped classroom, peer teaching, seminar, role play, all these are different methods. Flipped classroom works if the student reads and comes. If they don't read, then it is difficult. So what I usually do is first 15 minutes I will take a session, then engage them in an activity based on that. Okay? So different form, a different modified, Then to reinforce important facts, class feedback, all these by crossword, all these are innovative teaching methods. You need not use all of them in your classroom, but a teacher may become expert in one or two of these methods as the years go by. Okay. Then we have problem-based learning, jigsaws. Can somebody read the jigsaw loudly with a mic? Just anybody. Volunteer. I know all of you are motivated. Or blended, read blended. Anyone with a mic? Yeah.
Blended learning combines physical and online learning experiences
that give students more control over the time, place, and pace of instruction. Technology is a key component of blended learning as it is for students in the real world. The flexibility of blended learning enables students to have more control over their learning methods. They can choose according to their preferred learning styles, watch online lecture at home, and engage in collaborative activity with peer groups in college, or join lecture classes physically and work up independently, etc.
Thank you, Dr.
Lavanya. Lavanya.
Thank you. So there's a list of teaching learning methods there, and you can choose. First of all, you have to become aware of them and get trained in them. Most of them don't require any big training, just to become aware and know where to use it and which educational objective you want to achieve by using that application or interpretation. It should not be just to break monotony, but also to add some value to your whatever you have used. So coming to how to incorporate them into the current CBME curriculum. How to incorporate? We have to think of, see, we may have many excuses, many constraints, many issues, lack of, so many things are there. All of us are facing the same problem. But focus on what you have. If I see what I have is, I get an occasional class lecture. 1 hour the students are with us. If we are going to spend that 1 hour just talking to them continuously for 50 minutes, then it will not serve the purpose. So convert all your lectures into interactive lectures. As we said earlier, buzz, think, put all these things, maybe 1 or 2 every 15 to 20 minutes. Why 15 to 20 minutes? Because the attention span of most students and us is about 15 to 20 minutes. So if you don't break your monotony, break that lecture at that time, they will go to sleep. And after a little sleep, they'll wake up, and then they won't know where they have reached. And so what we are doing is just to break the monotony, break the cycle, and start the new cycle. New cycle means be attentive, then it grows, important matters are discussed, then it slowly comes down, then by another 40 minutes, another cycle of, you have to break it. So in those times, you use these interactive methods to break monotony as well as to achieve your educational objectives of, say, application, interpretation, all those what we have already. And your same thing you can do in your practicals and clinics also. 3 hours they are there with you, or 2 hours in practicals. Make them go through these educational objectives and they will become better learners, knowledge achievers, etc. Integrated teaching sessions, 2 to 3 hours. Let it not be just one person from each 3 departments coming, speaking and going. Most of the time that is what is happening. So it is not teaching, it becomes cheating. Put these exercises, put role plays, get feedback from them. Then there is what is called passing time. 8 to 4:30, between 8 to 9 after class there will be some half an hour which they spend in talking, going to canteen, all that. So that time we use to do project. So in our institution in microbiology, we divide the students into 20 groups. Say 90 of them, 20 groups, 3 to 4 in each group. Each faculty gets 2 or 3 groups, and we give them simple projects. Find out what is your hand flora. Go and do audit of hand hygiene in the ward. Give training to them. What is community? Like that, we give 20 projects to them and they do. And this is the, when they do project, that is when they work collaboratively, They're team leaders, they develop leaders, and they get to integrate, they get to apply. All these things happen when they do a project work. Then your assignments and whatever assignment you give should be structured for an SDL, self-directed learning. That I'll just talk about it. Okay. So we talked about these. These were on the left were all large group teaching methods, and the one on the right were all small group. So these methods, you be aware and get trained in these small group methods so that you can use them in your curriculum for different purposes. And large group, always make it interactive and make it a robust learning session. So why innovative? We started with that to promote active learning, break monotony, to overcome disadvantages of a traditional lecture, to reinforce. So every 15 minutes you bring in one take-home message, either in your exercises or in an MCQ, something, so that they go home with that message, reinforce. Application, all these you should try and achieve these in your whatever is there in your hand. What is in your hand? Your lecture, your practical, your clinical, your integrated. Don't let it go wasted. They are there with you for that time. It's big time. Now I give you a small exercise. I will pass one sticky. I will just give one for each participant. You will get a sticky. You have to write down names of 2 innovative TLMs you have learnt and you wish to use in your teaching, and for what purpose would you like, which educational objective you would like to use. Usually in a classroom, we don't allow them mobiles, so we use this kind of techniques. This is called post-it. This is called post-it, and this is used for reinforcing important points in my lecture. It can also be used for eliciting muddy points. Muddy points means doubts. If some areas you are not able to understand, not to the fullest, you can write that down, and usually we can use this for our attendance also. Write your name, submit it, I get my attendance, I get my feedback also. And on one side you can ask for, I am asking for 2 innovative TLMs. Back side, if you have any muddy points, you can write. And at a later time, you can call these students and discuss with them and, do the needful. All of you got your post-its? Yes. Please write down. I'll give 1 minute to write down 2 TLMs you want to use in your teaching sessions. And if you have how you would, for what purpose? For integration, for application, for interpretation, anything, or any muddy points on the back side. Once you finish, you raise your hand, our volunteers will collect it. You may not have these sticky papers. What we usually do is we cut one foolscap A4 into 6 bits and give them to each student. If we want some activity, we give 1 bit to 2 students. So it will become also a think, pair, share, or a bus session. So in one bench, if 3 are there, we give them 1 paper. They will put their names and answer my queries also. Very easy to do. If your students are sitting with mobiles in the class, well, you can have those, what is that, Mentimeter? Mentimeter, or any other innovative methods. Please submit all your sticky notes. Thank you. Shall I continue? Yes, okay. So as a facilitator, we have to see that there are student-subject interactions in your teaching session. It need not be between students and it has to be between the student and the subject. To convert all your teaching into vibrant, active learning sessions. Need not be vociferous or verbal. Can be silent. You give them a crossword, they'll be silent for 5 minutes. But what is there in their minds will come out. Give them a crossword, match the following. But don't leave them just by giving a talk. Next we go on to some stalwarts in medical education, Malcolm Knowles, Kolb's, Garnier's, all these. We'll just go through quick into their words of wisdom. So Malcolm Knowles, he described these, how to make students, stages of self-directed learner. See here. So initially, they're all dependent learners. Waits for test to read, waits for instruction. I find most of my students like this. From this stage 1, we have to convert them into stage 2. Stage 2, they are little more interested, inspired, strategizes learning. Okay, oh, this method doesn't suit me, I will do some other method to learn. Strategizes learning, seeks help. They will come to you for help. Then they become, stage 3 is involved learner. They are willing to take part in everything, whatever. They wait for some announcement. See, there's seminar, there's project. They wait for that. Active part, that is stage 3. And stage 4 is ultimate. They become a self-directed learner from a dependent learner. So, to convert them from dependent learner to self-directed learner, Malcolm Knowles has suggested these steps. These steps. So when you give them an assignment, okay, go and study anemia at home. So you should tell them also these steps. What are your needs? What is your goal? What does the teacher want at the end of 1 week? For that, what do I need? What are the resources that I can depend on? Otherwise, what the student will do is he will just read that portion in his prescribed book and come, that's it. But no, you have to expose them to other human resources, material, maybe go and read Harrison also. Choose and implement learning strategies. What are these strategies? Different strategies. Everybody's strategy is different. Some will study in group, some will prioritize, some will make a map, some will create models. Some of them may be kinesthetic learners. They are all different styles of learners. So they will choose different methods. And when they choose different methods and they will evaluate, so these are the steps that we have to show them off and on. Whenever you give assignments, students, you follow these steps. Then if you do this, then, and you give them opportunity to do projects, seminars and assignment, then they will become from stage 1 to 2 or 3 of self-directed learning. So if you don't tell them these instructions and you don't give them assignments, projects, they will not progress. They will still remain the same dependent learner. What does Garnier say? He says there are 9 steps to instruction. Gain attention. Did I gain attention here in the beginning? Yes? What was it? It is not, education is not filling buckets, but lighting a fire. So you have to gain the attention of the students by innovative methods. Gain attention, tell them about their object, what is it that you have to study, stimulate, recall. Did we do recall? Yes. Prior learning, you have to elicit, present the content in many ways, bars, charts, all that, concept map, provide guidance, elicit performance in the class, provide feedback to the students, assess their performance, maybe end of posting assessment you should do, and let them know, give feedback and enhance retention and transfer. So these are the 9 instructional steps proposed by Garnier, and we can choose 1 or 2 in our class. Then we have the Coles experiential learning cycle, where I am giving one example of concrete, means they will go with the doctor, they will see a patient, they will take history and do physical examination. That's a concrete experiences that a student has. Then next stage is they will see what is it that the patient is suffering from, differential diagnosis. Okay, they have done a reflective observation of what is happening in the patient. Then they will come to a working hypothesis and a provisional diagnosis, and they will confirm it by various tests, whatever, and then they will do a management and follow-up. So if it is a case of hypertension, every time they see such a case, there will be a rethinking, there will be reflection. Okay, what happened last time? Did the patient get cured completely? What was missing? Like that reflection they will do. And when they do this reflection, that is when learning occurs. When the cycle is completed many times for a particular disease, that is when the learning occurs. It's called Coles learning cycle. There are many other examples also. Take our lectures. Every time I would have taken, say, typhoid 25 times. Every time I take the class, always I make some change. And I use that change. And then I may think that, oh, that correction was not correct. In the next lecture, I will make another change. Okay? So, all learning goes through concrete experience, reflective observation, abstract conceptualization, and active experimentation. You go see the logbook. NMC says they should do this exercise 3 times. For us, Graham Stein 3 times. So every time he does, second time he should think, reflect, what went wrong the first time? What is it that I didn't know? Then do it, correct it the second time. Then third time when he does, he should become perfect. So that's the importance of following this Coles experiential cycle. We all become experienced if we go through this cycle. So definitely it's a challenge to educators. A good % of training is done by a junior faculty. Are they trained in education? No. When we are subject experts, are we trained in education? No. So this education component, that is why all of us are here. Training in education is a must, and even your junior faculty should be exposed to it. And remember, we all keep learning always. Learning doesn't stop. I am still learning. I may be retiring in a few months, but I am still learning. So there is an education component in all our teaching sessions, and we as responsible faculty, we have to be aware what are these innovative methods. There are so many different so many parts, curriculum development, everything. When you're trained, you will know that, oh, I didn't know that. So there is a word called program evaluation. So some 20 years back when I was exposed to it, I didn't know what this program evaluation is. For me, program is, say, dance program, that program. I didn't know that, only when I went through these workshops, I understood what is program evaluation. And program evaluation is important. Whenever you have doubts on anything, do a program evaluation of the method. Find out what is the problem and work on it. So training in education is a must. All lectures should be interactive lectures. They are there with you for an hour. Give assignments with steps of SDL. Frequently give them projects, assignments. Give them, be trained in PBL, give at least 1 or 2 problems in your year. Then 14 subjects, they will be exposed to around 25 problems. Some kind of problem solving they will learn. Okay? Then information technology enhanced learning, because students are very much involved, or they will actively participate in all blended learning, whatever, all computer applications, whatever you tell them, they are willing. Use that capability. We may have to go a step further and learn some things. But you use it, the students will be happy to take part in e-bridge learning and other methods which is mentioned there. Overcoming constraints, adhere to learning objectives. Don't digress too much. Stick to your learning objectives. Make a lesson plan. Lesson plan should be same for everybody. Your class may be different, but lesson plan. Put process. At this point I will give this. At that point I will take attendance by post-it, something like that. Use blended learning. Use technology. It is there. Everybody's hands it is there. Get trained in medical education, all techniques. And you must realize that you are there to motivate the student, to light the fire, not just to fill the bucket. Buckets will go on increasing. You can see in the last years itself, so much new buckets have come. So there are many innovative TLMs. It is up to us to use them wisely for a particular purpose in each of our teaching sessions. Change from a sage on stage to a guide on the side, and understand that education has a limit, but learning, there is no limit. Be a good lifelong learner. Okay. To summarize, today we talked about innovative teaching methods in large groups, in small groups. Whenever you use them for these purposes. And you should give opportunity to the students to develop these skills. If you don't give opportunity, they just sit in the class and go, they will not develop these skills. Interpretation, reasoning, all this, okay? So give opportunities. To give opportunity, you have to be trained. You have to be trained. So overcoming restraints is all about empowering yourselves. You may not use all those methods I gave in that list, but at least 2, 3, and different teachers will use different methods. And in 5 years, you will become expert in that. Okay? Plan for both content and process. Plan for it, otherwise it will never happen. So all of you know some innovative TLMs? Yes or no? Yes. Are you willing to incorporate them? Yes. And you know how to overcome them to some extent? Use what you have in your hands, and then things will happen, and you know, CBME will come to its fruition. Okay, thank you. Any questions you can address during chai time.
methods, how to incorporate in our day-to-day practice. Definitely I am benefited. I think from today on I'll make a change. But am I allowed to ask a doubt? Okay, ma'am, I do have a doubt because I am basically a traditional mindset person like many of us sitting here. In our class of lot of students, we call the so-called good students. But now we know that each student has their own potential, and we have a slow learner, a fast learner who picks up fast, who is innovative. So based on each student's difference, how to make an inclusive learning strategy. Is there any shortcuts or anything? Or should we go by the conventional good student attitude?
See, slow learners means they will learn. They are just little slow. I remember one student, when she comes for Viva, I will ask a question, she will just sit as though she doesn't know anything. But within 30-40 seconds, the correct answer will come. They are just little slow, you just give them time. So slowly I understood that student, I will wait for her. Otherwise, I will not wait for 30 seconds before the next question. Some people are slow, they will lead. That is the beauty of 100 students. They are all different. They are all different styles of learning. So our teaching has to be of different, should cater to, so there should be a video, there should be an auditory, there should be a working component, everything should be there. Then their learning will become complete. Some students will need a particular type of learning that slow learners, they will all make up. That is my experience.
Thank you, ma'am. To felicitate both our resource person, Dr. Marina Thomas, and chairperson, Dr. Nirmala, ma'am, I now invite Dr. Elizabeth, ma'am, Professor and HOD, Department of Pediatrics. Thank you, madams. We are happy to welcome two more renowned speakers who have joined us. I request Dr. Deepthi, Associate Professor, Pharmacology, to greet Dr. Elsa Sanatombi Devi, Director of M. Philippi Manipal Academy. I invite Dr. Suhaina, Associate Professor of Pharmacology, to welcome Dr. Gokul Essa, Associate Professor of Physiology, Sree Narayana Institute of Medical Sciences.
Proceeding with our sessions, Session 2 on mental health and well-being in medical education. To chair this session, I invite Dr. Napoleon R. Sir, former Vice Principal and in-charge Dean of Thoothukudi Government Medical College, retired Professor of Microbiology at Tirunelveli Medical College, currently the Curriculum Committee Coordinator and Head of Department of Microbiology. Welcome, sir.
Really, I'm very happy to invite Dr. T.V. Asohan, sir. He is our senior at Stanley Medical College. You know our Professor Dr. Ganesh. Ganesh, sir, classmate. 74 batch அப்படின்னாலே டிவி அசோகன் சார் பேட்சா அப்படிங்கக்கூடிய அளவுக்கு he was very nice, simple and always smiling face. He used to encourage, entertain anytime. He is very much involved in so many activities during his students' life. So on behalf of our Mookambika Institute of Medical Sciences, we are honored to welcome Dr. T.V. Asogan sir, a distinguished psychiatrist, educator and leader whose contributions have significantly shaped mental health care and psychiatric education in India and beyond. Dr. Asogan currently serves as professor and head of the Department of Psychiatry at Sree Mookambika Medical College, Hospitals and Research Institute, Chennai. He previously held the same position at Stanley Medical College Hospital, Chennai, where he mentored generations of medical professionals. With over 35 years of teaching experience, Dr. Asogan sir has instructed postgraduate students in psychiatry and internal medicine, as well as undergraduates and students in clinical psychology, psychiatric nursing, social work, and occupational therapy. Dr. Asogan sir has been instrumental in advancing forensic psychiatry in India. His presidential address at annual National Conference India Psychiatric Society in 2014 titled Forensic Psychiatry in India. The road ahead highlighted the need for integrating legal and psychiatric practices to enhance mental health jurisprudence. He is known for his contributions to mental health through research, authorship, and leadership. He has served as president of both the Indian Psychiatric Society and the Asian Federation of Psychiatric Associations, and was the South Asia zonal representative in the World Psychiatric Association too. A passionate speaker, Dr. Asogan is often featured on social media, television, and TED-Psych style platforms, where he raises awareness on mental health and legal psychiatry. Beyond academia, Dr. Asogan has authored 3 books in Tamil on mental health, aiming to psychiatric conditions, destigmatize psychiatric conditions, and promote mental well-being among the general public. Not only that, during the COVID period, his role was much more. He has given a lot of counseling to so many people from the families affected COVID people. Today we are privileged to have with us a visionary in psychiatry whose dedication continues to inspire and lead the way in mental health advocacy and education. Please, all of us, join with extending a warm welcome to Dr. T.V. Asogan sir. Over to sir.
Thank you, Professor Napoleon sir, for the kind words. Respected Dr. Mookambika, CEO, Trustee, respected speakers, respected faculty members, my dear friend Dr. Satish, and respected audience. At the very outset, let me sincerely thank for this opportunity. I'm going to talk on this topic, mental health and well-being in medical education, in 3 divided parts. Why the present medical graduates are facing problems. And second, what are the measures to be initiated by the management to prevent such issues. And third, of course, individual measures. The first sentence in the Harrison Manual of Medicine goes like this. Medicine is ever-changing science. What a visionary statement it is. In the last 50 years with the technological advancement, we have come long way from antibiotics to atypical antipsychotics from ordinary X-rays to functional MRIs, colonoscopes and other scopes, computer pills for interventions and investigations, and of course, artificial intelligence modulating data from which we are able to formulate treatment strategies and preventive measures. Medicine is becoming increasingly technical. So also, the medical graduate and the future therapist and the medical curriculum, they have to be in tandem with this advancement, with this technology. Then we have to go back and see the history of medicine. Gone all the days where doctors were considered as demigods. There is enormous amount of consumerism, and you know we are living in the world of information explosion. Google is also manufacturing doctors periodically, and they question our answers. One has to know the present state. In the beginning of the 20th century, the father of modern medicine, Sir William Osler, he said, a therapist with a technical knowledge and scientific update should analyze the patient's profiles so that he would be really coming across differential diagnosis from which he has to travel to the destination of final diagnosis. His statement, ordinary doctors, they treat diseases. Great doctors, they treat patients. It's worth remembering. 1992 saw the emergence of evidence-based medicine, and subsequently, I think, 93 saw the birth of patient-centered care. There is an emphasis in 2000 to integrate evidence-based medicine and patient-centered care in 2000, and for that they highlighted one important factor called communication. Communication doesn't mean that one has to indulge in a lengthy verbatim. I think the fundamental aspect of communication is listening, not the process we employ with our spouses. That is hearing. The listen in such a way, the patient is interested in talking to the therapist. And the therapist should talk in such a way, the patients are interested in listening to him. And 2007, there is a voice that patients also should be involved in the treatment-related decisions. And that was the period where they started highlighting informed consent. With the advent of proteomics and metabolomics, personalized medicine emerged in 2013. And with the genetic understanding at an advanced level, that probably helped us to really formulate novel treatment measures and also prevention strategies, and that is the birth of precision medicine in 2015. COVID-19 was a black swan moment, and we had to really be in the domestic milieu. Confinement was the way we really led our life. At that time, telemedicine, M-medicine or e-medicine, that was the avenue for most of the patients. The futuristic medicine is going to be personalized, patient-centered precision medicine. And here comes the holistic medicine. What is holistic medicine? It analyzes the impact of the physical, psychological, social, cultural, spiritual factors on health. It analyzes the root cause of the problem and tries to really restore the balance. Just possessing the technical skill and scientific knowledge is not enough for the therapist, and one has to possess the less emphasized traditional skills. It is not a philosophical preference, but an evidence-based necessity. Making a diagnosis of diabetes mellitus is easy, but one has to be emotionally intelligent to explain to the patient. He must possess high EQ. What is emotional quotient? Understanding his emotions, understanding the patient's emotions, understanding the interactions between his emotions and others' emotions, and trying to get the best beneficial effect of this interaction. Second, he has to be culturally competent. Just prescribing drug is not enough. Unless until he knows the socio-cultural background of the patient, I don't think the therapist would be in a better position to talk about the dietary regimen. Third, he is a collaborator. Imagine a doctor is making a diagnosis of depression with a suicidal ideation and prescribing a female antidepressant and lithium. Imagine the female is becoming pregnant. In the first trimester of oogenesis, there is a deleterious possibility of Epstein anomaly, and so the psychiatrist has to interact with the logician to switch over some other drugs. Another problem arises in the postpartum period if the lady is allowed to continue the antidepressant because the newborn is unnecessarily going to get a small dose of antidepressant. So this psychiatrist has to really interact with the pediatrician for any other suggestions for the child for feeding. Third is a leader. Quite often our leaders are probably opportunists, even in the medical field. When something goes wrong, the resident of the junior doctor becomes the victim or the scapegoat. If something goes wrong, if a mistake is committed, I think the therapist should really accept himself. And there is a beautiful article in American Milieu in 2015. It states that every 73rd day the medical information is getting doubled. So unless and otherwise he is upgrading his knowledge, he is going to be a frog in the pond. Next is mental health. Here, about mental health, a lot of misconceptions are harbored even by our colleagues, even by the erudites. What is mental health? It is a sense of well-being. It is an ability of an individual to operate strategies at the time of facing any conflicting situation, and at the same time, ability to really contribute in a meaningful way for the personal and the professional level. And here I would like to reiterate, nobody is normal, including me. A visitor to a mental hospital wanted to see the varied nature of the patient. He was taken to a particular ward and patients are asked to stand in a row, and he saw one person crying in a profuse way. Why you are crying? The visitor asked. I loved a girl by name Sheila. Hope nobody, no Sheila is here. Don't worry, my spouse's name is Sheila. I loved a girl by name Sheila. It was a platonic love. I wanted to marry her, but somehow I was not able to marry her, became depressed and got admitted here. Don't worry, you can always find another woman in your life. Maybe in the old age, I think it may start with sentiment and hence a settlement. That's a different issue. The patient was carried away by this brief counseling. Then in the fourth row, there is another person crying in the same frequency. He was not able to marry a girl by name Sheila. I am the unfortunate husband who married the Sheila and currently experiencing hell. One man's problem is another man's fortune. One man's food is another man's poison. What I think is my cognition and what I deliver is my communication. I am, you are, we are, analyzed, deciphered, concluded, assessed by our communication. We may think something else in an obscene way with a beautiful filtering mechanism thanks to the frontal lobe and control over yourself. By communication, we really try to give a different picture. We wear a mask. That's the reason I'm saying we are relatively normal. We are relatively abnormal. Whenever you see a mental patient, a psychologically disturbed individual, I think, remember this particular statement. Why present medical students are more stressed? I go by 2019 statistics by NMC. 1.4 million people appeared for the exam, nearly 8 lakhs qualified, 1 lakh and 50,000 UGs entered medical colleges, 30,000 postgraduates, 604 medical colleges, 306 government, 288 private, 10 semi-private. An MBBS packed with 19 subjects. There are presentations, assessments, lectures, assignments, clinic-based practicals, and examinations. Internship in government hospital is hectic with the limited resources, even in some of the private colleges. And junior doctors become the victim. And there is a poor support system. And some of the students, especially in the pre-final and final year, they go for the compassion fatigue. The so-called DRP, rural posting, I think, and you have the administrative and academic and clinical challenges. There are so many studies highlighting so many reasons for mental health issues. But I would like to quote the mental health survey conducted by the National Medical Commission, which was released very recently in December 2024. Diagnosable mental disorder among UG, I think present to the extent of 27.8%, whereas postgraduates 15.8%. 84% of the postgraduates, they have moderate to severe stress because back to back they have academic sessions. In a week, they have clinical meetings, symposium, journal club, night duty, and especially posting in casualty, labor ward, or IMCU or ICCU, hectic. They don't have rest. And suicidal thoughts are being harbored more by the postgraduates. By the time they have to think about their marriage, they are not able to strike a balance between the personal life and the family life, and separated. Though I think there is a little freedom, the separation from the mother-in-law, child may be there, and so many issues are there for the female postgraduates. Alcohol and tobacco, 19%, and extreme financial difficulties, 33.9%, because invariably most of the undergraduates, they pay more tuition fees or more other fees. 72.2% of the postgraduates, they complain that stipend is very, very, very insufficient. And this is another problem, loneliness, thanks to our gadgets. The present generation, probably they started believing that they have everything with a gadget called mobile phone. I don't want to go to theater, I think I can see OTT. I don't want to go to restaurant, yes, Swiggy is there. I think I don't want to go to shop, again I can get anything and everything. I have 1,400 followers, but you don't have any meaningful friendships. 39.1% they have loneliness sometimes. 1 in 10% among medical graduates, they complain loneliness. And suicide among medical students between 2018 to 2022, 64 among undergraduates, Kerala 9, Tamil Nadu 8, among 58 PGs, Maharashtra 11 and Karnataka 11. Reasons, academic pressure, lack of mental health support, and pressure to excel. Substance abuse, alcohol 40%. Another trend is emerging. In our days, I think men were drinking more, men were smoking more. Smoking was on the higher side. I'm talking about the statistics 50 years back. Now, women are drinking, they also started drinking and they also started smoking, and it has come to a significant level. Saturdays, I think really, they go to a restaurant and they prefer collective drinking. And cannabis to the extent of 8%, but dependent pattern is not seen in India. And alcohol and tobacco statistics is in tandem with the statistics of other worlds. And of course, stimulants and hallucinogens, rare. What are the stresses of MBBS students? First year, you don't know what is happening there. Academic workload, financial difficulties, very difficult. In my anatomy, I really vividly recall my viva. They were asking questions. I was indulging in titubation. Puriyala, subject theriyala. they were thinking that I didn't know the answer. அவங்களுக்கு தெரியாது, I didn't know the question itself. That was my problem, right? But unfortunately, the present generation, they are extremely sensitive. The present academic MBBS curriculum is probably making the postgraduate to think that a small mistake is a failure, a disastrous failure. And that's the reason they are really, in an impulsive way, they go for a terminal exit. Second year, the competition with the peer group. Third year, time spent for commuting and placements, romantic relationship becomes toxic relationship, and they are not able to strike a balance between work and life. And finally, when you're posted in the trauma ward or terminal illness ward and seeing the suffering of the patient, probably you go for a kind of a compassion fatigue. And risk factors for mental health issues. For example, for pulmonary tuberculosis, I can say the reason is Mycobacterium tuberculosis. But for mental illness, I don't think I can really categorically say there is one single reason or single cause for mental illness. The reasons are multifactorial. I may be having a genetic loading, my parents may be schizophrenic, my elder sibling may be schizophrenic, but there is no hard and fast rule that I should become schizophrenic. Problems in the person, problem in the interaction with the family, and problems in the social interaction, how I perceive the stressful incident, how frequently I am facing stressful issues. So many factors are at that time, what kind of support I am getting. These are all the factors to decide whether I should really go for a minor neurotic problem or a major psychotic problem or a personality deviation. Wellness. What is wellness? It's a general and personal sense of well-being. It's always changing and evolving. At times we feel good, at times we feel bad, but that should be considered at the personal level. Of course, it is supplemented by other levels. As a medical learner, what is wellness? Whether I am able to really contribute extra time for the research-related activities, whether I am able to show some interest for ICMR projects or some other projects, or whether I am really going beyond a level and preparing for medal exams. Am I in a position to think about my future? These are all the indicators of wellness as a medical student. There are types of wellness: social, mental, physical, intellectual, occupational. What is social wellness? How far the medical student is connected with the social milieu? How far his views, expressions, suggestions, desires are accepted? How far he is feeling a kind of a belonging? Second is the mental wellness, realizing his own potentials, ability to operate the strategies at the time of facing any conflicting situation and trying to restore the balance. For problems, I think there are solutions. For some problems, I think there are no solutions. You have to live with that. Very difficult. People are just probably tolerating me as a husband for many years. That is the problem of my spouse. So you have to accept and probably tide over the crisis. Physical wellness. It is maintaining optimal level of activity, having an adequate energy, probably allotting some time to really do some exercise, thinking about nutrition, and it is not just doing but being thing. Intellectual wellness is pursuing overactivity, how far I can stimulate my learning process, how far I can harness my skill or refine my skill, how far I can really indulge in creative tendencies. And occupational wellness is knowing about the hazardous issues in the work milieu and trying to really prevent and protect yourself. Burnout. Burnout is nothing but exhaustion of physical or emotional strength or motivation, usually as a result of prolonged stress or frustration. It leads to emotional exhaustion. You lose the passion for work. Sometimes you get a feeling, and the case anupu, in a case vandhudu, probably you don't show interest, 10 case paathen, 20 case paathen, I'm tired. Second, depersonalization, or treating the patients as objects rather than real individuals. And third, sense that work is really no longer meaningful. Sometimes you feel when you really know certified death successfully or very frequently in IMC ward as a DAP or DAS, you get a feeling. இன்னைக்கு தான் 4 விக்கெட் ஆகிடுது, கஷ்டமாக இருக்கும், ரொம்ப you feel very bad. And how it's really, having all the consequences. In the initial stage, there is an arousal. I think poor concentration, memory lapses, and you start avoiding people. And socially, you start withdrawing yourself, and depression, apathy, and negative ideas. And slowly the person, I think, may not be really participating in the social activities, unexplained absences, frequent sick leave, and slowness in the procedures. If your required work is probably fitting with the meaningful work, you will have a professional fulfillment. But unfortunately, they do not have any kind of a tandem relationship, and that's the reason we really suffer. What is empathy? Majnu was saying Laila is the most beautiful girl. Somebody retorted, sadharana figure maradana irukku. Get into the shoes of Majnu and see through the eyes of Majnu, Laila would be appearing beautiful. Sometimes, I think probably some ladies, they may be complaining severe headache or abdominal pain, and she is visiting various doctors, and finally a diagnosis of hysterical manifestations or functional pain that is made. Once the diagnosis of functional disorder is made, I think there is a reluctant attitude even from the psychiatrist's point of view. They may be thinking, you don't have any organic basis. No, we fail to really know the pain is real, the suffering is real. The cause may not be in the physical system, but everything is perceived in an indifferent way. So empathy is probably, perceiving from the patient's perspective. It is a cognitive empathy, appreciating others' mental state, automatic and reflexive. Affective empathy, reasoning with the feeling of others, reflective. And motor empathy, mirroring others' emotions. Compassion fatigue. If empathy is perceiving from the patient's perspective, compassion is something one step above. You just want to do something for this patient. I'm not able to do anything for this patient. This patient is dying. This patient is suffering. In spite of giving alleviating measures, I think he or she is not coming back to the previous level of equilibrium. You started really getting some negative ideas in your cognitive realm. So compassion fatigue, stress or tension that arises from frequent contact with the traumatized people, where we become preoccupied with the pain or the suffering of the other people. Diminished ability, flashback, intrusive thoughts, hypervigilance, feeling like a failure as a helper, and you have trouble in separating personal and professional life. How to overcome? Have a balance between compassion and empathy. Please share this emotional feeling with your classmate or start writing about this emotional experience. What are the management standards, measures to be initiated by the colleges to prevent mental health problems? 6 factors have to be considered. 1 is the demand, 2nd is the control, 3rd is the support, 4th is the relationship, 5th is the role, and 6th is the change. What is the demand? It's concerned with the work milieu. It's concerned with the workload, whether the educational curriculum is adequate, whether the students are skilled or the teaching or the learning. I think it is enough to really accept this curriculum, whether the students within the time frame would be in a position to compete and complete this educational curriculum. And what are the interventions? Curriculum review should be there. Students' view should be incorporated. And if there is any other concerns from the students' side, I think try to reduce the administrative bureaucracy. Inquire. You're not going to give from the packet. Guide them about financial management. 2nd, control. This is about how they study. I think some people may be really in need of a peer learning or personalized study. Encourage personalized study or peer study, and review each and every student's ability every 6 months. Allow them to get exposed to pre-recorded lectures or allow them to really attend workshops. 3rd, support. This is about encouragement, support systems, and review of resources. And faculty should be encouraged to help the students. And students should be encouraged to form their own community comprising of juniors and seniors in order to better learning process. And students should receive constructive feedback. And fourth is the relationship. Provide a conducive, supportive environment. There should not be any room for any ragging or physical or psychological harassment or sexual abuse. Enforce strict measures. What are the anti-ragging measures have to be advertised throughout the campus and see to that it is really followed properly. And whether the predictive policies of the management is known to other people, other students. Role. Tell them that he is a perpetual learner. Explain about all of the examination system. Announce early. Deadlines should be really known to the students well in advance. If there is any change in the organization milieu, that should be noted and should be advertised, and every student should know about it. And what are the prevention mechanisms for mental illness and attempted suicide? Pharmacotherapy. Maybe antidepressants or lithium if the person is going for active suicidal ideas, or non-pharmacological management in the form of cognitive behavior therapy, brief counseling or psychotherapy, and follow. For students at risk, screening, detection, intervention, gatekeeper training, which I'll be explaining later, and preventing access to weapons. For all students, there should be awareness programs, anti-ragging measures, stress management, time management, mindfulness, access to treatment. Secondary prevention, stress management. Talk about nutrition. And especially the duty room should be in a safe place, and nutritious foods should be served to the duty doctors, postgraduates, and exercise. Talk about sleep hygiene. Most of the psychological disorders, they are extremely correlated with the sleep disturbances. Even the established diagnosis of mental illnesses, when they are in remission, if the person is experiencing sleep disturbance, there is a possibility of relapses. Substance abuse, cognitive behavior therapy, mindfulness, and resilience. Tertiary prevention, destigmatize stigma about mental illness. Nothing wrong in seeking help. And include the family members. Mentor. Mentor is a role model. He helps at the personal and the professional level. He provides input, guidance about research, clinical work. He builds confidence, competence, and he acts as a coach. But the important aspect of the mentor, he creates psychological safety. Na irukka, I am here, don't worry, even if anything happens. If your teacher is criticizing, if you are getting below average marks, if you are marked by your peer group, I am here to help you, I'll provide emotional support. That is the basic expectation from a mentor. I think people talk about the group mentorship because of time and cost factor, but nothing like individual mentorship. And nothing wrong in reflecting his personal struggles. Nothing wrong, I think, because I'm seeing a person, is almost like a celebrity for me, he's a mentor. I have placed him in this position. Oh, he also faced certain failures in his life. So nothing wrong in really facing a failure and really tiding over the crisis. So mentor, nothing wrong in explaining his own personal struggles. And coaching. This is distinct from mentors and advisors. What exactly used in coaching? One is the inquiry, and second, encouragement, accountability, and reflection. If formal coaching, if it is helping a clinical practice, and informal coaching, it helps really in inculcating personality traits, self-awareness, and aptitudes and interests. Gatekeeper training. What is a gatekeeper training? Gatekeeper is a person who identifies the risk of suicide among medical students. Who can be a gatekeeper? Anybody, class leader, a particular assistant professor, or a teacher, or in the social milieu, I think any volunteer, or police, or any socially well-placed person. And what exactly is happening? He's given training for 3 hours about identifying the risk of suicide, and followed by didactic lectures, audiovisual depictions, and brainstorming sessions. And there is a pre and post assessment about identification risk with a particular validated suicide risk inventory scale, and the outcome is really good. This is important. This should be highlighted. There is a telemenace calling system for mental health formulated by Union Government of India. The number is 4416. It consists of a caller, IVRS band, counselors, and mental health specialists. If the person who is in need of a particular problematic situation, he wants to seek solution, maybe he wants to consult a psychiatrist or a psychologist in person, yes, facilities are there. E-prescriptions are there. And 52 telemenace cells are there, 23 mentoring institutes, and 5 regional coordinating centers. Till October 2024, there were 14.7 lakh calls. And it is reaching the unreached and vulnerable population. I think students should know this number. Second, another therapy, individual therapy, is mindfulness. Mindfulness is nothing but state of active, open attention to the present. You are without any kind of a judgment, without analyzing your emotions at the time of facing any conflict. You just observe, experience that state, become aware. I have a problem, I failed in the exam, there is a loss. Do not analyze, just go for a surface float rather than go for a deep sea diving. Then second, awareness. Yes, it had happened, I should accept it. Awareness and acceptance. They say it is reawakening a present state. Life is nothing but existing in a present continuous form. When you think about the past, you become upset. When you think about future, you become anxious. Live for the present. This has happened. Yes, I should be aware of it. Awareness. Second, I should accept it. People say mindfulness really helps people in a better way. Second, resilience. Yesterday, I think Professor was talking about resilience. Viktor Frankl. Viktor Frankl, as a neuropsychiatrist, he was really confined in a Dachau camp. He lost his father, mother, wife, brother. Almost, he became like a solitary reaper, and he lost his sleep every day. He used to sit by the side of the window and used to gaze the stars. One fine day, I think he had a flash of my idea in his cognitive realm. In this world, nothing can prevent negative event. He called it as a stimulus. Nobody has got the control to stop or prevent the stimulus. Then you have to respond. Here, what he said, between stimulus and response, there is a freedom. Freedom of choosing the response. Let anything can happen to me, but I have the freedom of choosing the response. As long as I have the freedom, nothing can affect me. He formulated a concept called logotherapy, and he had written a beautiful book called Man's Search for Meaning. If at all there is a book of survivor's Bible in the last 100 years, I would recommend that book. Please read that book, Man's Search for Meaning. What is resilience? It is adaptability at the time of adversity. If you possess all these 7 qualities, yes, you can proudly say, I can face anything. What is competence? Think about all your qualities you possess. Confidence. Try to think about whether you are in a position to use those qualities at the time of adverse situation. Third, connectedness. When you are having a problem, get connected to your personal level, social level, familial level, and try to be in tandem with all these 3 domains. Character, it is a fundamental aspect of your personality which differentiates right or wrong. I'm going to choose the right pathway. Contribution is a motivating factor. Coping is the actual dealing with the stressful issue. Control. Think that the locus control is within me. I'm going to face this problem. I'm really facing this problem. Whatever happens, positive or negative consequence, I'm going to accept it. People who believe that the locus control is inside, they have a better stress tolerance, they use their past ability, and they have better sustenance than people who believe for anything and everything. I think people look for external milieu. When I fail in the exam, the assistant professor failed me. No, he didn't like me. Do not set for cause for the failures, especially in the external milieu. cognitive behavior therapy. It's a wonderful non-pharmacological management, especially for stress management. What really happens? When an individual faces a particular problem, he automatically develops a negative thought. That automatic negative thought is resulting in unwanted emotions, and that unwanted emotions are not properly processed in the cognitive realm, which is disturbing the psychological equilibrium. Ask the person to revisit the particular same incident. Ask the person to think about other possible thoughts. Let the other possible thought substitute the originally occurred automatic negative thought, and the emotions could be averted, and it's possible to retrieve the previous psychological equilibrium. Progressive muscular relaxation, this can be practiced. It is based on a principle that when you are upset, when you are facing a conflict, both mind and body, they become tensed up. Try to relax the muscles of the body part by part. At one point of time, the head to foot, all the muscles are relaxed, and you will feel that the mind is also in a very relaxed level. Deep breathing exercise. There are 4, 7, 8. 4 seconds breathe in, 7 seconds hold your breathing, 8 seconds breathe out by mouth. And probably, another way of really, harboring a positive, optimistic thought when you face a particular problem. It is not thought substitution as we really practice in obsessive problems. When you harbor an optimistic, positive thought, I think endorphins probably they escalate. And the reward areas like nucleus, ambience, and ventral pallidum, they are said to be in a hyper-excited level. And your attention is good, concentration is adequate, and your judgment is beautiful, and you are like a settled batsman in the 10th over who could see the cricket ball, something like a football, and you would be in a position to smash the ball for 4s and 6s. Time management. Just, there are so many management techniques. I just want to say 6P. Prayer, proper prayer, planning prevents poor performance. Especially, in the examination study holidays, you plan that it would consume 100 hours to complete Davidson or Harrison General Medicine, and immediately if you start reading, only very few people would be in a position to complete it. Instead, take 10 hours, and during 10 hours you plan for it. I'm going to allot more time for central nervous system. I'm going to allot some time for cardiovascular, some time for definition, some time for investigation. Should I spend time for psychiatry? Not necessary. So utilize the 10 hours in planning. If you do like this, all of us would be in a position to complete within the stipulated hours. Flow. Flow is a psychological principle. Flow, people really getting involved in a particular work, they are totally immersed, totally involved, they are known as autotelic people. Have you seen in a rural tea shop, I think the two containers, between two containers, the person will be really indulging in an activity called decanting, reducing the heat of the tea. That's such a beautiful, I don't know, even Bharatanatyam, they used to say adavu. Nammalala summave oru idha edukka mudiyala. That is flow. When you are worshipping in a sanctum sanctorum, what you are experiencing, it's a flow. When you are interacting with your girlfriend, absolutely vibrating in her frequency or your frequency, avanga appa vanda, inda appa vanda, eva appa vandalum, we are not bothered. The conversation continues, flow. So when you practice flow, if you are able to modulate your anxiety in a better optimal level so that your performance is in flow like fashion, I think people know they will not be really bothered about the consequences. If people work for reward, people who practice flow, work itself is the reward. They don't seek any kind of an incentive, they don't draw attention. Nama chief varumbodhu da nama vandu apdi vela seira maari nadipom. For HOD varumbodhu, they never do that. You are enjoying for your sake. Practice flow. Humor. Humor is a fantastic quality, especially துன்பம் வரும்போது சிரிங்க. That was the statement in Tamil. Without sense of humor, approaching a problem is like taking an image with a tripod camera. You can take only one particular angle. But with sense of humor, capturing an image is like capturing an image with a drone camera. 360 degree you can take the image, and maybe if you have a sense of humor, at one point of time, immediately you react. You borrow some time, a sense of humor, probably that's called response. Maybe in that borrowed time, from a different perspective, you may be seeing a kind of a solution. My last slide, what are the recommendations to have a better mental health? Orientation programs we conduct, stress management, time management, talk about communication. Instead, along with these programs, ask the students to showcase their abilities. Let them have sports-related activities, let them have musical night, let them have talent show, let them have dumb charades. And for another 4 days, I think let them enjoy. Second, invite parents and family members. Anti-ragging measures, I think, should be strictly enforced. There should be awareness campaigning program about stress management, time management, brief counseling, gatekeeper training, and destigmatizing about mental illness, and knowing about telemenace. There should be staff-student screening, and the free medication and free treatment should be given, and regulation of work hours. This mental health survey, which was conducted by National Medical Commission, they recommended that they have to work for 6 days. 5 days, 6 days, 10 hours, 60 hours. The 6th day, 24 hours duty. So 74 hours, 1 day rest, and little lenient leave during maternity period, and especially postgraduates posted to the labor ward or casualty or ICU or IMCU. Next day, I think they should be really, handled with a little bit lenience. Safe and supportive measures, especially duty rooms. Duty rooms for the postgraduates should be in the department. And it's better, I think, to serve the nutritious food also. And supportive family and child care. If the person is having some psychological problem, maybe in a particular nearby hostel or nearby room, the mother or parents can stay and really help the student to really pass the exam. Assessment method should be changed. Instead of marks, go for a grading system, pass or fail. Even in announcing the results, do not publish the name. Just numbers are enough. And transparent and response grievance redressal must be there. E-complaint portal should be there. Mentor-mentee program should be there, and it should be properly evaluated. And so also gatekeeper training program. Supplementary exam. If I'm failing in April, I think there should be another exam in June, and there should not be any possibility of missing the batch. The batch miss pandrathu romba kashtam. It creates but they are little bit alienated. In Stanley, I had seen many people, some of my own classmates. Somehow I was below average. At the mercy of the examiners, I was able to pass. That's the reason. They gave me a pass. I didn't get the pass. And mental health well-being committee should be formed, and periodically they should meet. And this is my mind map for this particular topic. And more than that, I think try to really talk everything in person. And life exists in offline only, even for academics. And so many webinar programs you are conducting, anga potu camera mooditu irukapla, I think one-to-one interaction. There should be attempts to really make everybody communicative in the real sense. Thank you very much. Queries are welcome.
Really, we had a good messages, sir. The need of this hour. Filling the bucket is part of our duty. But this is a right time to assess the mental status of our students, to encourage them. Definitely it will be very useful for their life as well as for their studies also. We are having a good opportunity of mentor-mentee program that we have to utilize properly. At least once in 2 months, we have to call them to come and meet us. put so many questions. Let them come with just problems so that at the early level we can control it. Thank you so much, sir. Thank you. Any doubts, any questions you can raise? Thank you.
Thank you, sir. To felicitate the resource person, Dr. Ashokan, and the chairperson, Dr. Napoleon, I invite Dr. Rajan, Professor and HOD, Pathology, and Dr. Ganesh, Professor of Pharmacology.
Ganesh was my classmate, my good friend from Stanley.
You can go through the YouTube, so many interviews given by Dr. T.V. Ashokan, sir. You can go through the YouTube. So many interviews, so many speech you can get.
Dr. Napoleon missed one point. He is son-in-law of our soil. Okay.
Thank you so much, sir. Thank you.
Thank you, sir. Next, we have a session on community-based education, a practical approach for medical students. I'm pleased to welcome Dr. Sree CS, Professor and Head of Department of Community Medicine, and a former Assistant Surgeon with Kerala Health Services and Assistant Professor at SUT AMS Trivandrum to chair this session.
Good morning. The next session is being facilitated by none other than Thomas Chacko sir, and it is our honor to introduce Professor Thomas V. Chacko, Dean of Education, Medical Education and Professor of Community Medicine at Believers Church Medical College, Tiruvalla, and the founding director of the PSG-FAMER Regional Institute. Dr. Thomas V. Chacko is an eminent medical educator and academic leader with over 4 decades of experience. He was awarded the International Fellowship in Medical Education in 2002, which he completed with distinction at the University of Illinois, Chicago. He then went on to complete the prestigious FAMER Institute Fellowship in Philadelphia from 2004 to 2006 and was later invited to serve as his global faculty advisor. He was the founder director of the PSG-FAMER Regional Institute, where he led the 2-year FAMER Fellowship Program for South Asia from 2007 to 2022. He also served as Secretary General of CRAIM, and in 2017, he was elected President of the Academy of Health Professions Educators, India. Professor Chacko is widely recognized and is often invited as an external expert to university senates, WHO committees, and medical education forums, both in India and around the world. His core expertise lies in curriculum planning, program evaluation, competency-based medical education, accreditation, and academic leadership for education reform. He has conducted numerous national and international workshops and has contributed richly to educational research, it's a peer reviewer, editor, and author. He has also received grants from WHO, UNFPA, and the World Bank for his outstanding work in capacity building and raising global standards in medical education. His work has had a transformative impact on health professional training in countries like Bhutan and Indonesia. In 2022, Professor Chako was honored with the Lifetime Achievement Award in medical education by MAU India, a national network of 25,000 health profession educators. He has authored influential book chapters including Scholarship in Medical Education and Program Evaluation in Health Professions Education, and continues to publish in high-impact journals. Beyond his academic work, he is deeply involved in voluntary health associations and Rotary initiatives, showing his strong commitment to community service and social accountability. We are privileged, indeed we are privileged to have such a visionary educator and leader with us today. And with utmost respect, I invite you to the session, sir. Over to you. Thank you, sir.
Thank you, ma'am. Thank you, ma'am, for those kind words of introduction. I am aware that I begin with a handicap, in the sense that this is eating into your chai or tea time. So my session, according to the schedule, is over before it even begins. But it's an interesting topic, and I would like to introduce you to the many things. Many of those who are not in community medicine will find it interesting why this topic is there. So this is the outline of my session, why and what is community-based medical education. The competency-based medical education and community-based medical education, the relationship, and the need to align community-based learning experience ultimately to produce job-ready graduates. And what was the tagline of my topic given was enhancing holistic community-based learning by students. Way back in 1984, Harden et al. Proposed this SPICES model. It was at that time the educational strategy propounded. Student-centered, problem-based, integrated, community-based, electives, and systematic. And he proposed a shift from the teacher-centered, information-oriented, discipline-based, hospital-based, uniform curriculum, and apprenticeship curriculum. Now, if you ask ourselves, where are we now? 1984 was 40 years back. So things move a bit slow, but surely we are going into and steadily and focusing now to move away from hospital-based to community-based. Not in its entirety, some medical schools in the world are entirely community-based, but we have to use the enormous learning opportunities that present in the hospital itself. But when we have to keep in mind that the statement or the purpose of the basic doctor or MBBS graduate is to produce the Indian medical graduate. And we are also aware that we are in the curriculum transition from the traditional curriculum designed by experts in the field and to community-oriented education. And community-oriented education begins with the design of the curriculum according to the needs, community's needs, not what the experts felt. So community-oriented education refers to the objective of that curriculum. It is oriented and addresses the community's needs. And community-based medical education is part of it, of the community-oriented education, where the teaching learning activities for primary care are located in the community. So community-based medical education, the learning activities, some of them are, the training occurs in the community. So we are familiar with the goals of MBBS program. So have a look at that quickly and see, especially this bullet over here. Physician of first contact. Effectively as a physician of first contact of the community while being globally relevant. So that's a very broad perspective and objective that has been stated. So is our new CBME curriculum community oriented or community based? Reflect on it. Is it community oriented? So objectives or the goal that we see on the screen, they reflect, they are oriented to the community needs, preparing a physician of first contact. And so, but some of the activities happen in the community. So community-based education within the overall oriented, community-oriented, oriented to community's needs. Way back, long back in the 1970s and 80s, many of us who are here, the old timers, we would have been exposed to the ROAM program, the reorientation of medical education. Because in those times it was realized that teaching was entirely in the hospital, and so the students after graduation found themselves as a misfit and ran away from the rural postings or places where they were posted. And so the experts who wanted the education to shift from a hospital-based to a community-oriented one suggested we carry out some of the training in the primary health center. So even the specialists used to go and visit the primary health center and train certain competencies in the community or at the PHC level. Look at the outcomes and the roles of the doctor, clinician, leader, communicator, lifelong learner, and professional. Which of these is being addressed in the hospital setting? Patients, families, communicator with patients, families, colleagues, and community. To some extent it is happening in the hospital, but communication with families, with the community, the best situation would be at the community setting. Then responsive, a professional, responsive and accountable to the patient, community and profession. So that will happen only when the students are taken to the community and they will be learning and given a chance. So some of these, it's possible for the community medicine department, but together with teams, they need to take the students to learn and observe the tasks being carried out in the community so that they can correlate. Otherwise, the teaching of the subject becomes theoretical. To make the teaching community-based, how many of you are happy with the training that is happening in the community medicine or in the institution itself? generally the thinking, it's all theoretical. And students find it tough to relate to what is being said. So this can change only when they see the reality in the community. And also how the curriculum is being implemented requires to be redesigned, reoriented and implemented in a systematic way. Because now community medicine is synonymous with textbook of park. Students also don't call it community medicine, they say SPM. So and finally they read that textbook and that they can pass. So that's the reality, but we need to, if we want to make them interested and be job ready for doing the task in the community at primary care level, we have to take them and make them aware of and learn in the community itself. So to begin with, we have to do an alignment exercise within the institution. The curriculum has to be aligned, and this has to be made clear even to the students that you start with the professional task, and for bring to their attention that the graduate outcome, what are the graduate outcomes, and then the subject-wide competencies that are there. Fortunately, we have now the UG curriculum document available, accessible to the students, and we teachers must bring it to the attention that a particular competency is what they are going to learn when they go to a field experience. And we need to design the learning experiences through a curriculum matrix linking learning experiences to competency progression. So if we look at, we are mainly interested in making our graduates job ready. And what are the tasks of the medical officer working in the PHC? It says curative work, preventive and promotive work, national health program implementation, training of staff as well as people in the community, and administrative work. So that being the case, that should be the starting point, and we need to identify which of those competencies can be community-based. So this is an example of community-based medical education matrix planning for each task. For example, identify and manage common important health problems. So what competencies are required for that? And then during which posting that can happen. The second task is to train, support, and supervise other members of the health team. So how is that to be implemented? Validate and interpret data collection by health workers. So that is the important role of a medical officer at the primary health center. So unless the medical officer himself is trained to do those things, then he will not be able to supervise the work of the health staff. Implementation of specific national health programs to monitor them. What is being done now? So we need to take them for PHC visits, get the students to interview them and things like that. And of course, internship program, they are posted at the PHC. So these are the various, there is an alignment between the tasks and the planned learning activities. So I strongly recommend that within the department, when we plan out or implement a curriculum, we need to really evaluate and review what is being taught. And is it connected to making them job ready for the task of being a medical officer of the PHC or the doctor of the first contact. So we have the 5 years exposure from first year to the internship, and if we look at the tasks, they are targeted and distributed: care provider, leader, indifferent decision maker, manager, communicator. So when we look at all these tasks of the graduate, and then in the curriculum planning, we identify the learning experiences when these can happen in the time available in the timetable for them. I want you to think and identify what are the types of community-based learning opportunities that is happening currently. Think, write it down, check with people on your table. Use the mic and let's have some interaction. Anybody? Okay, family adoption is there. That's because it is recommended by NMC. No other go. Okay, these are what the examples that are coming. They are related to the training that are prescribed. Okay, what else? Good. So literature classifies community-based learning opportunities into 3 types: service-oriented programs, research-oriented programs, and the core training-focused programs. Training-focused programs are the ones that fit into the curriculum and teaching schedule. And the concerned department plans the respective learning experiences to carry out and prepare the doctors for primary care. Now, service-oriented program. I want you to respond whether these are being implemented in your institution. Community development. Some of you did mention family and a family adoption program, and one of the stated objectives is to improve or adopt a village so that at the end of the 5-year period, that village develops. Any other? See, community development, most institutions especially, have the additional responsibility, a corporate social responsibility. You are there existing as an organization, and people's expectations are high. In addition to providing health care of the tertiary care level, there is a social obligation also, and many organizations and institutions undertake projects, outreach projects, and there are developmental programs implemented through the urban and rural health training centers. That's already there. So to develop rapport with people in the community, both the urban and rural health training centers, in order that the people welcome the students when they go and knock at the door, there has to be building of trust, and they must get something out of it. So before that happens, there must be many developmental programs and activities that need to happen in both the urban and rural health training centers, apart from what you're providing through the outpatient services. So any such activity being done, please tell, so that there will be a wider dissemination of information in this audience. Okay, camp is a common thing that institutions find it easier to reach out to people in the community. But camp is often a temporary measure. Camp is a good thing to begin with. Okay, any other? Pardon? Cancer screening is a kind of an obligation. There is a public demand, there is a need, as well as the institution gains lot of trust by conducting these special. It's not obligatory, it's not mentioned as a requirement by NMC, like the family adoption program. But screening for breast cancer or whatever, all kinds of things, when initiated, it contributes to building of trust and contributes to community development also. Any other? Okay, so early detection of disabilities, okay. Hearing. So these hearing, visual and other early detection programs are part of camps, or it could be adopted schools. So these are all extra activities which we call as community developmental activities. In addition to that, we have health interventions like school health and health outreach for elderly. Now the southern India population is all becoming mostly elderly. When you go and visit homes, you feel only the oldies there at home. The other generation people are almost very negligible. And yeah, palliative care is another emerging need, and the institutions rise to the occasion to provide palliative care to people in the community. So I am listing out these activities, developmental activities and interventions are happening, and it makes sense to take smaller batch of students when these activities are going on. And when they see their own role models providing health care in these settings, it enthuses them to and interests them to learn more. So it is a good opportunity to expand your community-based teaching activities beyond the usual training programs. So usually students observe, and when they are interns, we can involve the interns in actual conduct of these programs. So it's an experiential, actual immersion into their activity. Another thing we have to remember, there is a dilemma. When in the first year, for example, the students do not have the skills of diagnosis, and they have not yet learned about pathology and all those things. So how to use the student? So we have to remember that health results from development. So developmental activities, community development, better housing, better sanitation, improved water supply, education of the people results in better capacity to purchase food, better housing and things like that. In fact, as part of our projects in the place that I was working, the objective of the project was improving adoption of family planning and adoption of small family norm by empowering the women, by encouraging them into community developmental activities or income generating activities. And as a result of improved income of the women, they could say no more children. So it is empowerment, and such projects are there. And when students see and observe the social determinants of health can influence the health, it becomes a good opportunity for them to connect between development and health. So better utilize, it is beneficial for the organization which organizes these services and develops. Because when family income improves, the families can not only they gain the trust of the organization providing the service or development, but their capacity to purchase the service. The fees also improve. So it's a win-win situation, both for the institution as well as for the people. And this is easily observed by the students, and we need to focus on that and make use of all these opportunities. Another very important and useful opportunity is health education. So a lot of opportunities present to the students to be involved either in the OP itself, or when the patient is waiting in the waiting area before entering the consultant's chamber. Those people waiting in the waiting area, their time can be used by encouraging the students to give health education. Of course, the students need to be trained in giving health education. And also similar opportunities to be given in the community. Community-based education can also be in health facility-based or community-based. So can someone in the audience look at these points, programs, and tell if they are happening in 1 or 2 sentences? Yeah, just tell what is being done and which area. Health facility-based at the urban and rural health center. Many institutions also have ICMR projects or Department of Science and Technology projects, or they interact with the health system, or some of the teachers are involved in program evaluation of the national health programs. Any other situations where in your organization this is happening? Okay, community-based research program, effectiveness, utilization. All these, if it is not happening, you should start thinking of taking up these activities. Because in many of the recommendations at the WHO level, it was felt that the teachers should be seen implementing these research and developmental activities. If they see the teachers only taking classes, then they can't connect. And so we should be encouraging the faculty to undertake both health facility-based research and community-based research. Research, we all know, it helps solve community problems. So when we are designing research projects for the students, help them to identify what is the problem and what research design they will choose so that it solves the problem. And then how will they measure whether the program has, intervention has been effective. So through simple community-based research projects, they learn various competencies needed for program planning, as well as identifying the indicators of success, as well as opportunity to plan educational program evaluation as an intervention to overcome or solve the problems. And the additional advantage is they can, once you charge them up, once you ignite the fire and interest, then they will be happy to do it on their own free time also, and at their own time and pace. Then we have the familiar community-based program that are mandatory, and there are opportunities for us to implement them, take them to these learning opportunities that are happening in the community. So when the students do the research and the activity in the community, they learn, and they are doing it in teams, so they also learn about leadership and development. So what needs to be done to make students' learning motivating? See, generally what happens when they are taken for community-based learning experiences, it's a picnic for them. It's just an activity, there's a bus ride, they go, and so to convert this picnic into a learning opportunity, we need to do certain things to make it effective in achieving the purpose of the visit. So make them aware that through the process of lesson planning, the onus is on us teachers to plan. Those who are accompanying the students and supervising and guiding them, the teachers themselves must consciously do lesson planning, explaining to them before the students are taken for the field visit, the relevance, why it is being done, and the link to make them job ready. By going to the field, what is it that they need to do, how is it relevant to them for the job that they are likely to carry out, and link with the relevant prior activities that they learned, and briefing what to expect. So we have to have specially designed checklists and observation checklists or interview schedules that the students take to the community. They collect information themselves and then they present in the classroom and there is discussion. So mentor and supervision presence of them is important, and then they measure the performance of the students and their participation as a team when they are collecting the information. So when students know that their performance and activities is being measured and monitored, then they will do active participation. So there are, the basic principle involved is reflection on the experience. Encourage this to happen. So it need not be, reflection need not consume lot of time. It can be quick reflection and asking different students to reflect in say 1 minute. So a collective verbalizing of the reflection of different students, it helps them understand the varied nature of learning that happens. So asking them, what was the experience? Why did they go to visit the milk dairy or the PHC? What did they do? It helps them or boosts their knowledge retention. And then they observe, and as a result, the next part of the reflection is, so what? So what is in terms of how they, and what next is how they will use the knowledge gained to improve their abilities next time and their connection to their job responsibility as a doctor of primary care. So it improves performance and relevance. So the benefits of community-based learning for students, to the individual students, it improves their knowledge. It's a varied experience, and when they have gone through the experience themselves, then when we take a class or a lecture, then we can ask them to recall what they saw, and whatever words we speak, it makes sense to them. And you can ask them to recall and connect what is being taught, or in group discussion, they would have already seen and learned in the community, and so it becomes easy for them to discuss. So, experiential learning, and it motivates them to learn what we are teaching. Otherwise, it is dull and boring. It also helps additional things. For example, situated learning, cooperative learning, students learn from each other. They are sent out in teams and they learn from each other, and they form a community of learning. There is a debriefing session after the visit, and all that, it improves the learning. So to sum up, community-oriented medical education is to meet the community's needs. Our NMC curriculum of UG basic curriculum is a community-oriented curriculum, and some of the activities that are carried out are community-based, and it is important for the departments implementing community-based medical education to do actual mapping, so that you become clear that some of these important elements are not missed. Otherwise, you will be busy doing the routine things. So you need to do a matrix, and the community backward planning helps you to link with the ultimate purpose or the goal of education and training. And community-based is best learned experientially, and it can happen as part of the institution's service, as well as it can happen as a part of the research activities of the institution, as well as the training commitments which are mandatory. So these are the possibilities, and experiential learning, making them to reflect and capturing it in the logbook and the portfolio, where they actually record the evidence of having learned, and combined with assessment of that learning will ensure that they are job ready and competent. So the importance of community-based medical education is engaging with the community. That is a unique experience. It's a challenge. When the patient comes to the hospital, the patient is in need, in pain. Whereas when you are going to the community, you are the pain for the patient. So it's a challenge in communicating how to get the doors to open and find a foothold into their homes, and making the people welcome them, develop rapport. And in that sense, the family adoption program is consecutively visiting the same family, and over the years, it is possible for the families also to benefit from the visits by the students. So that is a indirect kind of payoff for the students, and students become their family doctors. So it's a good program, and we have been studying the various problems encountered, and with time we will have a better program. Thank you.
Thank you, sir, for that very enlightening session. And each of sir's words came from years of passionate pursuit of this subject. And actually, we community medicine people usually say that our lab is a community. That is a concept, but it's easier said than done. As sir said, there are so many challenges. Actually, we are interrupting their work, the community. They are not coming to us. We are going there. So there should be something for them also in that. And as sir addressed the challenges, it's a real challenge, sir. When we go there, and when if it becomes a superficial thing, they will never allow even the students to enter the compound. So this is a real challenge we are facing, and sir has beautifully depicted the roles of the IMG, which incorporated into this FDP thing. What all can be done in a community-oriented way. So it was really enlightening, and we are really lucky to have you here, sir. And the floor is open for questions and discussion. Thank you.
To felicitate both our distinguished resource person, Dr. Thomas Chacko, and the chairperson, Dr. Jayasree CS, I now invite Dr. Vinu Gopinath sir, our esteemed Deputy Medical Superintendent, Trustee and Professor of General Surgery.
Thank you all. After 5 minutes break to recharge ourselves, we shall continue with our formal sessions.
Hello.
I can't keep here now. Hello, 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 hello. Yes. Hello, hello, yeah. Hello, hello.
Okay, we shall resume with the session. Session 4, Interprofessional Education and Collaborative Practice. To chair the session, we are honored to welcome Dr. Suganti S., a NABL Technical Assessor, MEU member and Professor of Biochemistry at SMIMS with over 10 years of experience. She has served as a resource person for various workshops, including the revised basic course workshop and research methodology.
So good morning one and all here. I feel very privileged to welcome you, Madam, Dr. Elsa Sanitami Devi. Yes. We are honored to welcome Dr. Elsa Sanitami Devi, our distinguished nurse educator, researcher, and academic leader in health professional education. She currently serves as the director of Mahe Famer International Institute for Leadership and Interprofessional Education and deputy director of the Center for Continuing Education and Interprofessional Development at Manipal Academy of Higher Education. She is also a professor and quality management representative at Manipal College of Nursing and the president of the Gerontological Nursing Association of India. She holds 2 prestigious FAMER fellowship, one from Mahe and another from the International FAMER Institute in Philadelphia, USA. She has currently completed the R-Phase Competency-Based Education Fellowship from CMCL Ludhiana. On the top of everything, an award-winning academician. She is a National Florence Nightingale Awardee 2021 and received the honor from the President of India in 2022. She has also received multiple recognitions including the Team API Gold Medal, Best Research Paper Awards and accolades many from the national and international organizations such as NHS, UK, Rotary Club, Global Training and Education Center, Mysuru. She has co-authored and authored several textbooks and academic chapters including the popular Manipal Manual of Nursing Education and published numerous corpus, indexed and high-impact journal research papers. Her primary area of expertise includes dementia care, interprofessional education, wound care for both MBBS and nursing, medication safety, geriatrics and advanced nursing practices. She also served as a coordinator and speaker at over 30 national and international workshops and conferences and has conducted programs across India, Malaysia, UK and USA, focusing on innovative care models, dementia training, simulation and interdisciplinary collaboration. She is also actively engaged in cutting-edge research with ongoing projects on dementia, abuse prevention, cultural humility, pressure injury apps and health innovation using AI, 3D printing and mobile technologies that shows how much she is in interprofessional collaboration. Her global collaborations includes projects funded by the Scottish Government, USIF and the University of West Scotland and among others. She is also a recognized trainer in leadership development, wound care and patient safety and has certifications from Johns Hopkins University, University of Colorado and Coloplast, India. Tireless advocate for community care and social innovation, Dr. Elsa has initiated health campaigns, cancer support programs and grassroots public health interventions impacting thousands of lives across India. We are truly privileged to have such a dynamic and inspiring leader with us today for this interprofessional education and collaborative practices. With that, so thank you.
Thank you, Sugandhi, for the nice words. With all my respect to my guru sitting here, Dr. Chako, Dr. Tejinder, and my new, very young leader, Mookambika, who is here, for whom I have come all the way from Manipal, and Dr. Diksha here. I think I know her last 26 years at Manipal, and we are very good friends and good neighbors. We are all here. I think I'm only nurse standing here in front of you. And I just asked whether all of you are from medical, and I said 100% medical. So, but I think we got to be a good human being first. Forget about what profession we have gone into. We have dissected our body into brain, specialized into brain, heart and all that. But I think what is most important is how happy we are as a human being, and as Chako sir has rightly said, what are you giving to the community? At the end of the day, those of us who have grown little older will understand what is meant by growing older. And sir has rightly said today, if you go to the beautiful homes, the so-called mansion that you built, they are no other than just maybe a couple of older adults being there. So what is that one thing we can do as individuals? So before beginning into the session of working together, Mookambika has requested me to do something with the audience. And Dr. Asokan has rightly spoken on mental health. All of us being doctors here, first thing when people have problems, they come to you with a history of having bad feelings or bad emotions. What do you do first? First is prescribe medications, right? And all of us as people who come for help also, we are looking at one tablet that solves all the problem. But can we really solve it? I don't think so. Now we need to distinguish, when we have problem with our mind, we are treating our brain. Are you getting me? We have problem with our mind, feeling low, feeling bad in the mind, but we are treating the brain. Give a lot of antipsychotic as well. So all of us in the health profession, we need to understand, is that permanent or temporary? Am I going to eat that medicine permanent or temporary? So we need to understand where we treat ourselves. That's the place where I went down to do my specialization in emotional freedom technique. We can heal ourselves, we can heal others. Very well we can heal others, and truly we can heal ourselves. So all of us are teachers. What is that one thing you have in common, all of us? When young students come to the campus, what do you feel like? Excited? Number of classes? Excited with the number of classes? Counseling? Getting teacher guardians? You get 10 students to mentor them for next 5 years. What is your happiness in it? Tell me one happy thing that you feel when new graduates come in, or you have the 4 batches along with the interns. How do you feel as teachers? Someone is smiling at me. Do you feel stressed out sometimes? Yes. Can we work on any one of them? Any one area you want to work on? We are many. Individually, stress are different. Stress of having? Is it too many class? Yeah, people who are married will have different problems. You have family also, class also, you have students also, patients also. So let's work on it. All of us, please leave your hand free. I know this was coffee time, but leave your hand free. Yeah, all of you, please put your hand together. We are taught by our parents how to pray. God is everything to us, is it not? So let's use our hands, because why we have problem with us, either in thinking or body problem, is because we have not, we have block in our energy. If you are here today, it's because of energy you are here. If there was no energy, you wouldn't be here. So when there is a block in the energy, we are not there, right? So we have blockage. Let's work on it. So please follow me. Okay? Yeah, you can tap. You can tell the same thing, that you can repeat what I say also. Okay? Even though I have lots of students, and they trouble me at times. They don't listen to my classes, and I feel I'm stressed out sometimes. But I still deeply love and accept myself. Please repeat with me. I still deeply love and accept myself. Even though my family is hard for me to manage. Family, college, students, patients, it weighs on me. But I still deeply love and accept myself. Please, louder. I deeply accept and love myself. Even though the days are not so easy, it's hard sometimes. With my workload, sometimes ill feelings, sometimes not so good things happening to me in my life, but I still deeply love and accept myself. Please, a little louder. Energy. I still deeply love and accept myself. I'm all set to take home all the messages given here. To be a good teacher, to be a vibrant teacher, to be a marvelous teacher, a mentor, who will my students, below me faculty, my peers, because I deeply love and accept myself. You're accepting yourself? Some feeling is there? Okay, I won't go beyond because of the time frame, but there is a way to work out. Maybe towards the end, I will also do some other techniques to tap on. So today I've been given the task of looking at interprofessional education, practice, and collaboration. So how do you work together? All of us, we are so learned now. That is why we segregate. Super specialty. But when we come as a patient, whom do you look for? I want a good doctor. I want a good nurse. I want a good technician. End of the day. But we have split. 1 year, one specialty, another year, leg also above the knee one, below the knee one, left hand, right hand, we have super specialized. But as a human being, what we need is working together, learning together, working together, and collaborating together, because our life here on earth is very short. It's a short journey. But what have you kept for people to remember you? That one thing you want people to remember you. Whoever we are, whether great or small or big, doesn't matter. People will remember you for how you make them feel. And that is what is rightly said in the proverb. So how do we do that? All of us have worked. How harmonious is our working environment? You as doctors, you go to your clinics, you have so many people along with you, and maybe they are looking for what my consultant is coming for the round. But what did I give to them? What smile did I give to them? What emotion did I pour on them? Is it my anger, my happiness, my smile, my nice words? Choice is yours, whether it is negative or positive. Positive, you will have better interaction. Negative, you lose your friends. But how do we work together? So we have been doing this. Interprofessional education, practice, collaboration is not new thing, but we are trying to emerge and learn new, because we have forgotten to talk to people, we have forgotten to work, we have forgotten to acknowledge people. And that's the place we are looking forward to look at. Oh, my slides are okay. So we are forgetting to learn together. Now for me, right from beginning, maybe I narrate as they are fixing the technological part of it, maybe I can narrate a little thing about how I came into nursing. Nursing was never in my list. But I wrote for my medical. Problem is, if you don't have money, those days entrance makes no sense, because you pour money, you get anything, and if you don't have money, you don't get anything. Because tragedy hit me when I was 10th, and then I had to lose parents. So it was very hard for me. So I never thought that I would come to nursing. My mom asked me when I was going for nursing, are you sure you're going for nursing? I said, I'm not sure, but I'm going, I said. Because seeing one needle, I can run away from home. I was so scared of one needle, and mommy asked, sure. This one question made me to think. So I said, if I have to do even nursing, I said, I will make you proud. And that's the stand I took. So nursing doesn't limit me anything. Because nursing is one person, you can relate with so many people, and you can heal so many people. And that's where I landed up in Manipal 26 years back, and I have not gone back. People ask me, in my Aadhaar card is all in Canada, and in my airport in Manipur, they look at my face and they look at my Aadhaar card. It's something strange to them, and yeah, it's working now, thank you. So my slide pattern has changed, okay, fine. So for me is to orient you all what is IPE, IPP and IPC, that is practice and collaboration through education. So unless we learn how to sit in the classroom together, we are not going to have ease in the clinical area. So if you put these students together, I remember when I joined as undergraduate, biochemistry, anatomy, physiology was common class. So I know all my MBBS friends, I know all my allied friends. So when you go to clinical, we are like one friends and we go in a gang and work together. But today, all of us put our classrooms separate. Then we expect them to work together. Where is it possible? Unless I have a boyfriend or girlfriend from there, otherwise it's not possible, right? And that is the working environment that we have created. So it is to build some effective skills. How do you work with people? Communication is something we learn right from the time we are conceived. We have learned communication, but in profession we have forgotten to talk to people. And that's the basic skills that we need to attain. And to identify some of those common barriers, I think you make the slide little smaller because my content is going out of coverage. So I'll go ahead with that, no problem. So IPE is nothing but when you learn to work with, from and about each other. So we need to work with people, you need to know about them because you need to respect their profession as well. It is not only my profession. Without, see, you have all your 5 fingers, both the hand 10 fingers. We value some of them, but if you have pain in one, you have really have problem because every finger has its own values. So understanding others' profession, understanding their roles and responsibilities, keeping in mind the ethics we need to abide by. I think that makes sense for us to learn together and practice together and collaborate together. Something is going wrong? Yeah, that's fine. Okay, I think yeah, it's okay, no problem. Something's out, it's fine, no problem. I think the slides are too large this way. Yeah, yeah, it's okay, fine. Yeah, thank you. So now if we look at IPE, so I have looked at certain literature. We don't have to even look at literature, it works. Because without working together, it's impossible for us to function. Improve patient outcome. So WHO already is saying that IP is key to building collaboration practice ready for healthcare workforce because this is the way forward. Manipal has taken up with the FAMER Fellowship on Interprofessional Education. Now the globe has 11 FAMER regional institutes, and of that 4 are in India, where Dr. Chako has started up in South in Coimbatore, Manipal, and CMC Ludhiana, and then GSMC Mumbai. So they are already 20 years old, and then Manipal is just 10-year-old in fellowship program. But we have taken up as a unique theme on interprofessional education because I think we need to start somewhere and work. We need to be working very, very harmoniously. So WHO has already said it very clear. So why IP? Because it enhances teamwork and communication. We learn communication. Medical college, EdCom is famous thing in that. We learn it, but most of the communications are taught in the classroom. How do we teach alone in the classroom? People need to interact. People need to interact. First of all, when you have your students, medical students are all from all over the country and even outsiders. People come and get shocked. So in fact, we have also developed some other module which can look into that. I'll come towards the end of the session, and that really works out. Communication is not just to be taught in the classroom, we must learn to make them interact. So what we have done is the voluntary service organization is teaching local language. So when the students join in the first few weeks, we give 15 hours of spoken language for the local language. Learning local language is very important. Here, how many of you understand Kannada? Okay, I'll translate, no problem. When I came first time to Manipal, people were very excited because I was the only one person with the small eyes, and yeah, with monkey cut, I had long hair, now I chopped it off, and the people look at me because I look very different. So my classmates were ready to experiment on me. First posting was community. So they said, when you go to community, see house and see women in their marriageable age, you ask, Akka Maduve Aita. Means, Akka, are you married? So if she says no, you ask, Istu Makalu. Means, if she says no, I'm not married, ask how many children. Okay. So I by-hearted whole night, Akka Maduve Aita, Illa mean Istu Makalu, okay. But for me, first time learning, when I went to community, I saw a woman, I ran, they pulled my chuni and said, Elsa, you get thapar on your face. And that's how my classmates experienced. But I learned those naughty things, and that's how I learned Kannada. And people don't hear what I'm saying. They are watching me how I'm saying. Because now also patients are very happy. I don't have to do anything much. If I say Namaskara, if I say Telugu person, I say Bhagnara. So if you know every language, at least 2-3 words, you make their day. Ask someone unknown. Nobody will expect that I know Telugu, right? So if I ask Bhagunara, they're so happy. So if you touch them with their language, you can be a wonderful person to that patient. You may not speak everything. Not even now today, my Kannada doesn't have is, was, where is not there. Grammars are not a big thing, but people understand because you are not from there and you are trying to. And this makes a lot of sense for us to understand. So team communication and teamwork. So already there are a lot of researchers saying that the impact is it reduces medical errors. So when you communicate well, we are talking about patient safety, there is huge error which is not reported in India. US is reporting, and medication errors are the leading cause of death in the US, where they report everything. In India, where to report? We cover up. Any mistake, we cover up. And still our statistics is very high. So this is saying that we got to do safety work because we can communicate well and do a good teamwork. If you have done your good communication, we can reduce error. I'm not saying errors won't be there. Errors are there. That's why Institute of Medicine rightly said to err is human in 2000, and that's where patient safety is looked at all over the globe. So next is system efficiency. All of us are making medical college, allied college, nursing college, one corner, but accessibility, efficiency of how we work together is very important. We need to ideally think when we are making new medical colleges, new institutions, new organization, please look at wholesome to how we can be together. I'm not saying every subject you can learn together. At least some common subjects where they can be taught, where they can mingle is something very unique that we need to think about when we are making it. To the old one, we have to cut and paste. It's very difficult, but when people are making new things, we need to understand this. So when system efficiency, because we all work in silos, we all work, we are like horse. We work like a horse. We see only this much. We don't see what's happening here. We don't see what's happening here. So we need to understand that identifying key departments where you can function together. I am not saying that all students from 10 colleges will come and sit. Then it will become, like convocation. It is not possible. But key topics, key departments where they can sit down together and learn together, that will have. For example, take pharmacology as a sub. Any pharmacologists here? Yeah, at least one I see pharmacologist. You take the same, yeah, some pharmacologists are sitting out. What's his pharmacology? Fine, that's great. And so, like for example, you take pharmacology as a subject, just take one subject. Every health science student learn pharmacology. And we all learn very differently. And the same pharma teacher who teaches is not supervising in the clinical. What is taught in the classroom, somebody else is supervising in the clinical. So the clinical pharmacology is not touched anywhere. And who is explaining to every patient how the medicine works for them? We are talking about compliance, huge compliance we are talking about. That the doctor should explain who, now, who should explain? Either the doctor will explain, the pharmacy will explain, the nurse will explain. Who explains to the patient? Nobody. Prescribe, they give 2 minutes, we go. The doctor expects the nurse will explain, the nurse expects the doctor will explain, or somebody else. Who will do it? We have no idea. Who explained to them? And we talk about big compliance. Where is compliance? We never ever tell our patient how this medicine works for you. That same medicine is given for multiple health problems. But how do you explain to them? And we talk about please comply. Where they'll comply? They'll put under. And we talk TB should come down. TB is rolling and rolling again in India because we have not actually touched the problem of their assessment on their non-compliance factors. So assess current relationship, schedule regular rounds, prepare thoughtful questions, act on the insights. So in the clinical, we say all are leaders. Every profession will say we are leaders. But situational leadership should come up here. In any situation, who is that one leader? There will be somebody who is leading the team and there will be members. For another situation, maybe another leader. We cannot find a permanent king in the clinical. We cannot find completely a queen in the clinical, but there should be situational leadership that works out on patients, case-to-case basis. So this is actually improve the system. So improve patient outcome, enhance staff satisfaction, increase operational efficiency, better resource utilization, and then we are talking about quality care. So when you enter the hospital, you are not entering as a teacher, you are not going as a consultant, you are not going to go as a nurse or as a doctor to find quality. You enter as a patient, then you'll understand what is quality. Enter as a patient, then you will tell me what is the quality of that particular healthcare system. And that's where we need to define. So when we talk about IPE, some things are covered up. So professional identity, you may think when we say IPE, I will lose my identity as a doctor, I will lose my identity as a nurse. No one's identity will be lost. That is why you have white coat ceremony, nurses have lamp lighting ceremony, we take oath. All of us take oath, isn't it? We take ought. How many of us live with the ought? So that one is over, white coat is one, everything is forgotten. Now we are taking out, even aprons are not in the clinical because of infections that is creeping into the clinical. Our students will not wash. When it becomes brown, they'll throw the police there. For that reason, now we are restricting people wearing apron in the clinic. ICUs, no way. But still, some people still wear, some people still wear and walk around. But because of infection control measures, we are having so. But with the ought, how many of us live this many years? That ought we took when we were first year, when we were in first semester. Did that ought remain till 5 years or 10 years, 20 years or 30 years? That commitment is what we are looking at. But we will never lose our identity. Okay? We will never lose our identity. Keeping our own personal, professional identity. When we are in group, we can also have group identity. That's why we call health profession. Now there's a huge team working towards health profession education, is it not? And we have so many associations. Why are we having this? We are having this so that everybody comes in. Because health profession education membership is not only for people of only one kind. We are multiple people into that. That means we are trying to form an identity of serving people. But as serving people is not there nowadays, we are looking at personal benefits. What do I get from this particular association? So we need to understand there are also some factors that we are looking at. Some people feel that the IPC, the predominant single professional education may result in a professional identity among healthcare students, which may support successful IPC. So sometimes some people have negative notion about it. They feel that identity will be lost. It will not be lost. It will enhance you as a good doctor, as a good nurse, as a good, say maybe a physio or whatever you want to name them. So personal proficiency is different. So when you go as a patient, all of you sometime or the other would have got admitted. I thought so many times. So when you want to look for a good nurse, you choose for your good doctor. You have, for that one problem you are, which doctor is good? All of us will do that. And that is your personal competency of being a good human being and being a good doctor. We don't go and fall for every doctor to treat you. We look for who is the best. Who is that person who will take care of you? And most of them will not be only physical expertise, clinical expertise. They look at you as a good whom you can talk to, who listens to your problem. And that is what Dr. Asokan has spoken on, mental wellness. It's very important, and that's everything that can heal an individual. So meeting global healthcare challenges, we have too much problem. Indian population is huge. If you go to the market in the city only, we cannot take your car, crowded, right? Now, Marilina is here with us. In the US, you go to, but there are problems in the US, and we have huge potential to grow also in India, because our population is huge when compared to any country except China. We have huge population. For this population, what are we going to do? But we are still very nice, I tell you. Today, you take an appointment, you can walk into your doctor's chamber. But in the US, you need 6 months to get your one appointment. But when they come that one appointment, they get everything, I tell you. When I was in Boston, I was looking at, they have only 5 patients that day. Only here in India, one doctor has 300 patients to see. That 300 is their lifetime patients. For us, is one day number. So they have only 5 patients. They have huge number of healthcare professionals. So these patients from station to station get everything done. That one appointment, because no more appointments in the next 6 months except in real emergency. But here, at least in India, we get to see a doctor. Even outside the hospital also, you can see in their personal clinic, in their home, wherever you want, you can see your consultants. But that facility is not there. Though we criticize our population, still we are big human beings if you look at. But how can we improve that? How can we make our younger generation? Today, all of you sitting here, another 5 years, you are going to receive your alpha group generation as your first year MBBS student. Now these iPad babies, the alpha, how are you going to manage? By the time we'll grow a little more older, 5 more years older, some of us will retire and go out also. The remaining teachers, how are we going to manage? The same group is coming to us. And we have all generations, all X, Y, Z, all generations are in your department as maybe professor, associate, assistant, lecturer, whatever you call it. and you're going to manage, you as a leader is going to manage all those. So understanding how to work together remains very important for us. So I have got one acronym, China map. So the climate change, you can look at, well, now today we are facing climate change issues with global warming. You see how many earthquakes? Can you stop the water? You cannot stop the earthquake, you cannot stop the water. If tsunami comes, we'll be all washed out, right? India took so many years to survive through the tsunami. Now so many things are happening in the world. The world is not at peace. And our healthcare is also trembling sometimes. So how do we make that possible? Okay, look at some of the global challenges. So when your students take up projects in groups, please let them sensitize them to some of these global health issues, which is affecting definitely our country in a huge, so they can work up together so that at least they'll realize. So I'm not defining everybody, but mental health remains very prominent, and today aging is a big problem. ICMR gives, this time ICMR grant had one area on elderly. We are also applying because I very closely, I work for dementia, and elderly are very close to my heart. Imagine today none of us are going to be spared from death. We are going towards that only. We are not getting younger. We are getting older. Tomorrow, if we look at dignity, end of life, what is that dignity, how it is going to be defined? Nobody knows. Now children are all migrated, nobody is there. Then where are you going to look ahead? You have paid so much, you have struggled so much, because marriage is 25-year project. You look after your children, they become big people, they all fly out. You are alone. How are we managing about dignity at the end of life? We need to understand, we need to strategize. We can't sit idle. We have to think, what can I do? So that at least I die peacefully, I die with dignity. And that is what we are looking at. So aging population is a huge area of scope where you can make your students together, faculty work together towards achieving, because another 10 years we are going to have more elderly than youngsters. And the youngsters will all fly out all over, and then we have more elderly population. So what are we going to do for sustainability? We need to look at. So current time professional functioning. Many times we have distrust among ourselves. Huge. Distrust is very huge among ourselves. Ineffective communication, many times I remember one sentence between the nurse and the doctor. A little funny, but you can bear with me. How the nurse has communicated. Here the patient, patient is having not able to pass urine. So over the phone, the nurse says, "Doctor, patient is not able to pass urine. You come and pass." Means she is asking him to come and at least prescribe something. But sometimes, English is of course not mother tongue, is father tongue. But when we miss, it means a whole lot of difference. In our day-to-day communication, sometimes we think that person has to understand what you are thinking here. But what we are saying is different than what we are thinking here. When we understand, because for Indians, we are low context people. If you look at communication, we are low context, means you should read between the lines. But if you go to America, everything has to be written down. They are high context people. They need to be written down with everything. For us, we need to read between the lines. But how can these young students read between the lines? How can the young faculty who is so vibrant and looking for marriage look at what you are thinking and saying? There could be a lot of mental blocks, and because of the communication pattern that's happening between you and the next person. So this is in one way miscommunication. Stress and burnout is very high today. Everyone is getting mad. That's why they sometimes break and give them a retreat, holidays, come back. Sometimes again you go 2 days, come back to the same workplace. But you cannot change people. We can only change ourselves. So if you are a happier person, you can be a better person in your institute or in your department. So conflicting roles and responsibilities among healthcare professionals, overwork, and sometimes, because in India we do not pay money for people who have overworked themselves for the organized. But in the West, for every hour extra, you get your pay. But here there is nothing like that. We work sometimes 18 hours also. But who looks at it? Because you take up responsibility, that's why they'll tell you. But if you do not see this, if there is a supply and demand issues, there can be issues in the organization. Role confusion, disengagement, lack of collaboration. So if I'm only in that one unit, If I'm collaborating only with nursing and nursing and nursing, I don't think I can do experimental studies. So I was just going out and see if they can do, why not I? So when I was working on advanced wound care, because I do a lot of research in area of wound care, so coming out even with a mobile app, anybody, any caregiver in the house can take a pic and it comes to our servers and we can tell you this is stage 1, 2, 3, 4. So if it is 1, 2, what to do is already in the app. If it is 3 and 4, you may need you may need a debridement, so they have to come back. So this is happening, and so we are already patenting it. And then I said, this is not the end. Now we need to go down to experimental research. So we went down to do animal study. Now we are looking at OBGs. We get placentas, the umbilical cord. Okay, we are taking it and using for wound healing. The research innovation doesn't stop anywhere. When you find a problem, remember this is an opportunity. Every problem is an opportunity. That opportunity you must work on. But you cannot sleep and work. You have to dream and work. Sleep means you will sleep. Idea also will go, patent also will go, research also will go. But it is not alone. As a nurse alone, I can't do everything. So I have scientists, I have engineers, experts to look at many things. So I have other basic science scientists and also animal experts. So together only we can do something, because I have no idea some of the techniques. So I was learning from them, but learning from them is not complete because they are specialized in that area. So we need to have multiple teams. So when you apply for grant, they'll look at who is a subject expert for this particular procedure, for this, who is that, for this, who is that. So they're looking at the team members when you have to receive a grant. And that's important for us to work together and share credit as well. So sometimes people are, who is the first author? So for me, is the person who gives the maximum effort should always be the first author. In many places, I see that the guide is the first author because the student is scared and they put the guide first. I said, why? The student who is doing the work should be given the credit. The guide can be a corresponding author, but that too depends if you have done some work. If you have not done any work, why should I be? So we have to be authentic. The authenticity is coming in, looking at ethics. So look at core competencies. Core competencies is looking at, how you interprofessionally when you work and collaborate. We work on 4 basic competencies. One is values and ethics. Keeping in mind and ethics of every profession. Ethics while handling the patient, values and ethics while dealing with the interprofessional team members, and also roles and clear roles and responsibilities. What, suppose if there are 5 members in the group, what each one is going to do? Or you go to clinical, what is each one's roles and responsibilities? We do not have a clear demarcation. Somebody tries to be leader for everything, that doesn't work sometimes because it will cause unhappiness, because I also have my certain roles and responsibilities, my identity is there. So that has to be very clear cut, understood by all members. One is clear communication. If there is a clear communication between the members, I don't think any of the confusion will creep in. And next is teams and teamwork. Unless you understand each other, team cannot happen. Team spirit. So for me, till I came to nursing, I was always in the ground. I was a national player. So half of my time was always in the ground. So people didn't have to teach me teamwork, because when you played football, only one ball, right? Everybody is kicking on that one ball. Yes, but if you don't have team spirit, how did one, if I am only one person take the ball here, there and try to score the goal, it won't work. It's a team. If you want to succeed and get the best, it is teamwork. But one must, as a team leader, you must acknowledge your team members. This is very important to raise their morale, otherwise they lose the interest and they'll say, let him only do, let her only do, and it will die, have a natural death. So keep up the team spirit, please acknowledge your team members, give credit for your team member, then only your team members will function for a lifetime, not for only the project, but for a lifetime. So understanding these 4 important aspects are important in IP. Some challenges will always be there. Sometimes we are little stereotyped, okay? In hierarchies, I am the boss, so whatever I do only, whatever I say only you do. But we need to understand. So whether the leadership is, a hierarchical leadership or egalitarian leadership, means I take consensus of the team members. So you need to decide. Decision is yours. So whether you consider the consensus or consider yourself as only the leader and the boss, and that may not work all the time. So you must understand when you do project, You cannot be stereotyping. Institutional resistance, lack of faculty training, overload in the curricula. If you now look at the MBBS curriculum, when I was trying to, we do some programs in the foundation program, and when we look after the foundation program, if you try to do 1 hour work in MBBS, you will not get any slot. Timetable is jam-packed. Having the curriculum jam-packed, are we producing good doctors? Now you will all touch your heart and say, have I produced half-hearted doctors, or have I produced good doctors? We need to understand. It's not about your number of hours of curricula. It's I finish my teaching classes, I am done. But have I made a good person? That we need to think over in our curricula. There is no place. So scheduling conflicts, these are conflicts. So when I want to conduct for them program, they say no timetable. Well, that foundation also is now jammed, completely jammed. Okay. So possibilities. So one is we have to have a mindset of buy-in from leadership and stakeholders, role modeling by champions. So when we say IP, it is now people in the beginning they ask, what is that IP? What is that IP? Please come for the workshops, come and enjoy. I tell them come and enjoy. Because when you conduct workshop for students, there are 2 things you have to see. One thing they'll ask, ma'am, is there food? I said, yes. Is it non-veg? Yes, then they'll come. Not because they want to come for your workshop, but the moment they come in, they enjoy the workshop, they start interacting, they are okay. Next time you call, they'll come. But those who have not experienced, they'll have that mindset, go or not to go. Second thing is, what will they get out of it? If you give certificate, you give credit, they'll come. But our mindset is stuck to that credit. But of course that is good because students are growing, they need to fatten their CV, so that is why they are asking for it, because tomorrow they want a good job outside, not here. So we are almost preparing graduates for exporting, and that is how we are looking at when we're looking at for our country. So curriculum integration into the curriculum is one factor that we can achieve. Goal alignment, evaluation, evidence, I think is well spoken by many of the speakers. So challenges how to appreciate the quality of its members. One is lack of awareness could be another challenge. Negative bias that he is like this, she is like this, he'll be like this. Okay, these are the biases, but we need to understand the individual. Competitive culture, communication barriers, insecurity and fear, time constraints, lack of recognition, personality conflicts, and leadership role. If these challenges are taken care of, I think your department or your institution will be the place where people will love to work. So it's way forward is our mindset. Only change our mindset, that's it. Sometimes we used to think how to handle these small ones. I said they are the most lovable people. Only problem is they have some problem with the issues of gadget, because that gadget also, who has given the gadget? Parents have given the gadget. Okay? Many of us are parents and grandparents here. Some of you, how many of you are grandparents? I'm grandparent to 7 kids, and I know how it. The younger children are very lovable. Only thing is they are gadget, but that gadget also very innovative. If they are used for good things, it will be good. They are used for bad things is different thing. Our students are not less. They'll hide their mobile, shoes under the socks. You tell them don't bring. They'll do anything anyhow. So sometimes in the class I tell them keep your mobile on the top, use it. So I give them exercise on that so that they'll not see other things. They'll see my things there. So it is technique. As the previous speakers have rightly said, innovative techniques, how do you use and how do you engage them? And that's very important for us. So mindset change. Change for learning together, change for collaborating. So we must introduce, always people think, let them come and talk to me, then we sit like this. But then I think I have to get up and say, hello, hi, I'm so and so. What are you doing? At least ask. And otherwise, how do I know who is who? But we sit and wait, let them only come. Why should I go? This is our mindset. So we need to change our mindset, get up, have energy, and talk with people and choose. I'm not saying that everyone you talk will become your friend, not necessary, because sometimes we have to see our wavelength also. When we collaborate, need to see similar mindset. Okay. So IP teaching learning can be already. I think the first speaker in the morning has dealt with all these areas of looking at. The one nice thing which I learned in the FEMR is IP escape rooms. That's right. IP escape rooms are very interesting. First time when they introduced online, Because before starting the FAMER program, we have so many activities they have put. This escape room was something that was amazing. So online only you have to search. It's like a talent hunt. Something like talent hunt. It's an all group of students, mixed group of students. We are searching where it is. So we should know how to get out through the door. So like how you do talent hunt, they give you some instruction, they give you some tips, and they walk around. This actually makes them merge, gel, and then work together. So these are something new. Other than that, almost everything is already spoken in the morning. So evaluation of, you will think how to evaluate. If these students come together, which teacher is going to evaluate? Who is going to give them assessment? It's a concern. But it can be very well done. It need not be done for every procedure, but can pick up few things which we can do. As Sir was talking about family program, that's the best place if you want to see communication. Peer communication. They are going out, right? Send them, all the healthcare professionals, medical student, nursing student, they all go for community posting. Send them together. You see the Vellore model, CMC Vellore model. The student, public health student, the students, medical student, all go for community. 1 month maybe they are in the field. They work together, come back and present together. I think that model will work completely with these students. So let them assess how they communicate with the local people. The peer can assess. The teacher need not be even there. Because assessing 250 students is not easy task for the teacher. Unless you do a simulation, otherwise not possible. But how on real patient, how one interacts could be different. So faculty evaluation, self-assessment, self-reflection is well spoken by Sir or the IP team observation in the real world clinical settings, case reviews, debrief, and FGDs. This can work out in any new organization where you are just introducing IPE. I think these are the places you figure out what is best, which will work best, and you can start in small ways. So we talk about collaborative communication because we talk with a consensus goal that we are going towards patient safety. Everything, it boils down to patient. Today, if students are not there, no salary. If patients are not there, where is our salary? There is no one. Our customers are very important to us. Maybe I'm talking from the technical point of view as customer, but if students, the medical college doesn't exist, if there are no patients, students, where will they practice? So these are things we need to look at. We have a common goal, and that goal is built on trust and integrity. If trust is there, nothing is there. Even in relationship, if trust is not there, nothing is there. So we must build that trust, which is very important. Integrity is doing, even if your boss is not watching, you are doing what you are supposed to do rightfully, and that's important for today it's actually healthcare. Medicine used to be very simple in the past, ineffective and relatively safe, but now it is very complex, effective, and potentially very dangerous. So what decides drug and poison is only dosage. Only one pharmacology person is here. So what differences between a drug and a poison is only dosage. So we need to understand and think that taking care of. So this is a small story where Emily Jerry was lost because extra amount of sodium was administered by the technician, and we lost the person. So there's a triangular effect in medicine, nursing, and pharmacy. If you look at very closely, just that one medication turn around, if the physician has given a wrong order, and if the pharmacy has dispensed it, and the nurse is giving it. So any mistake in one of these circuits will go wrong to the patient. Now who will be blamed? Let me suppose the patient has died. Now who is to be blamed? Whom to blame? Yes, so nurse here always is blamed, but then who goes to the court? The doctor goes to the court because you claim that patient is mine. Because this is warning. So one must understand the policy in the healthcare has to be clear. In Indian healthcare policy is not very clear. That is why today you will find doctors most of the time in the court for somebody's mistake. And this is for us to understand. So if you work together, so closed loop communication is what we talk. I'll just explain you with an example. So the surgeon shouts out, hang another unit of blood. Now who will hang? Who will hang? There are so many people standing around. The nurses are there, technicians are there, so many are there. Who will hang? Nobody knows, okay? Nobody knows who is going to hang it. But in a closed loop communication says, Mary, hang another unit of blood. And Mary hangs it and says, I have hanged another unit of blood. All right? And this is where we look at simulation remains very important for undergraduates training program, because they don't know, every procedure is not going to be seen. Now undergraduate program is like go around and watch around. Only when they do internship, they are little serious, they start checking BP, they start checking temperature. Otherwise the whole year program, all subjects, they are wandering in wonderland. If you look at where teachers are going and seeing, and professor has 25 students around with them, it's like bagpiper going around. But have they really, you assessing it, how are you going to do it? These are common concerns that you will see in any institution. So using some of those closed loop communication techniques will work. SBAR technique works very well, and this should be emphasized in the organization. So when we look at this one patient, suppose somebody has diabetes, so the moment, see diabetes, somebody will highly comply. Even if you highly comply, another 15 years, some complications will come in. Oh, all the pathies. Which are the pathies? From head? Neuropathy? Retinopathy? All the pathies you name under the earth, all the pathies will come in. So we need to identify pathies, mean now how many people are required? You need all the doctors for all dealing all these one pathies, right? Then you need all the healthcare professionals. So are we working together or isolated? Today I will go to endocrinologist, next day I will go to the podiatrist. Then one patient will roam how long? One patient will roam how long to fix one problem? So if you are working together, if you have a clinic where you can see multiple people to see that patient one time, it solves the problem of the patient. Solve my problem, their problem also. But we don't work together. So the patient has to do touring. By the time he gets fed up, and he may go to Ayurvedic department. So we call medical shopping. And we scold them for medical shopping. And if the patient has gone to another department and come back, sometimes doctors don't see them also. They say, you already went there, you go there only. Our ego comes in between. Okay? So these are situations where a unique patient can suffer from. So working together always helps us together. So if we do not have in the curriculum IPE will not work. If it is not in the policy, it will not work. But in a small way, it has to be there. So it is a willingness of the administrators, willingness of the clinicians, willingness of the faculty to work with. Maybe start with a small thing, and you will see the wonders that's happening between the learners. And these are some of my success stories. First, my fellowship, I did medication safety. So I have here in the picture, you can see my medical student, dental student, allied student, nursing student. My medical students, first time they are doing an IV cannulation, they are doing blood drawing. All these things are small skills. So when you cannot get your vein, you look for a pediatrician, you look for a nurse who is working there 20 years. And entry also want to learn. Very, very happy to learn these small skills. So these are how students learn. This is another advanced wound care. I also run the Interprofessional Advanced Care Wound Center 16 credit course, which is collaborated with Coloplus and European Wound Society. So they get 16 credit course. When they go out of the country, they can work as wound manager. So I have my medical students, my nursing students who come together to learn together. I even simulate. Some things are being simulated even on fruits. In the classroom, you can't get patient every single day. So how do you do debridement itself is a skill to be taught. You are simulating so that when they go in the real world, they'll at least understand how to do it and how to go. But remember, our skin is very tender, not like fruits. That also is there, but it can be simulated. This is another which I introduced in FAMER, and cultural humility. All of us boil down to trying to understand. We come from different background. Patients are coming from different background, and sometimes tomorrow we don't know what's behind it. So to understand culture, their beliefs, their norms, and being sensitive to the culture of that patient, and competency, able to do it right after assessing the patient is called cultural humility, completely. People talk about cultural sensitivity, but humility is above sensibility. So one must understand that if I know the patient's requirement, I'll be a very good doctor. I'll just give an example here. It's running out of time. When we work, these are medical doctors, and I also have my foreign graduates coming in between. So different countries, even India has huge differences. Caste, creed, how many languages? Too much, almost 2,000 plus. How many tongues? I don't know. How many caste, creed? We are so different. Even death ceremony is different. In the same religion, death ceremony is different for the caste, different caste. So it's huge difference. So if you want to be a good clinician, want to be a good person, I think understanding culture, humility will make you a very, very good person. And so challenge management is cultural barriers to be understood, institutional resistance, resource and infrastructure challenges that we can use it together, faculty resistance for readiness, policy and regulation, time constraints, and managing institutional faculty skepticism. What will happen if not also what is there? What if works out well? So if you think it positively, everything will end probably. So as I feel, because all our faculty here, faculty development remains single competency, because if faculty are not prepared, how am I going to prepare my students? It's like you want to make dum biryani and you don't have chicken, don't have rice. Then how are you going to make them chicken biryani? Not possible. So we need to be prepared. So development remains single important factor for the same. So we believe in working with, from, and about each other. With this, thank you so much. If any questions, I can answer.
So, thank you, Dr. Elsa. That was we all walked and we are made to walk and join with you in this session. I just wanted to highlight a few things. The IP escape rooms, that was very new to myself, and the best practice of collaborative practices has by the reversal role, and that was very much emphasized, how the communication will happen. So that was very much emphasized. And one more thing, she made us, we are all working towards the holistic care, but how far we are working to teach the holistic medical education imbibed from the all generation coming, like from to the alpha she has pursued. So thank you, Dr. Elsa ma'am. And with her 2 fellowships and crossing the language barrier and cultural humility, it's always a learning for everybody, I feel. To me also, I am also new to this place. Thank you, ma'am.
To felicitate both the resource person, Dr. Elsa, and the chairperson, Dr. Sugandhi, I invite Dr. Sree CS, Professor and Head of the Department of Community Medicine.
Thank you, madams. Moving forward, session 5, Transforming Medical Education, the Future of AI in Shaping Healthcare Professionals. I am honored to welcome and invite to chair this session Dr. Vinu Gopinath sir, Professor of General Surgery, Deputy Medical Superintendent and Trustee of SMIMS. Professionally, he is an accomplished urologist and a highly skilled laparoscopic surgeon. Passionately, he is a tech enthusiast and an expert in the field of artificial intelligence, constantly inspiring us with his forward-thinking approach. Over to you, sir.
So, good afternoon. I think our session is standing between the lunch and so just the pre-lunch session, and I believe that Gokul also needs to leave early, so I'll not be pushing too much. So just a brief introduction about Gokul. Gokul I know from my BCME and ACME days, so we were for those. So one great thing that I understood about him is how much tech savvy he is. He's actually, first thing that I came to know about him is that he's having a YouTube channel. I think after this, your subscribers might increase also. So it's called as a bloody physiologist. So it's a very, he puts out a lot of innovative way of approaching physiology and how to understand physiology by taking certain other news items or some other factors and then incorporating our physiology teaching into that. And he's at present an associate professor in Department of Physiology in Sree Institute. He has many certifications from prestigious institutions like Stanford University, University of Glasgow, ICMR and all. It involves a lot of varied tech areas like simulation-based learning, biomedical visualization, 3D bioprinting, and of course artificial intelligence in medical education. So I'll not take much more of the time. Over to you, Gokul. So this is another one issue that we constantly face because Gokul, unlike most of the presenters, have prepared his presentation in Canva, and I think the technology did not keep pace with how much fast he's thinking. So there are some technical issues. So I think he's trying to rectify those. Please bear with us.
Now I request Dr. Vinu sir to felicitate our resource persons, Dr. Tejendra Singh. Dr. Tejendra Singh sir, please come to the dais. Now I invite Dr. Biju Gopal sir, HOD Ophthalmology, to felicitate our resource person, Dr. Swaminathan sir. Welcome sir.
I'm really sorry for making you wait. I know I'm standing between you and the lunch. And there is a real concern that AI might replace healthcare professionals. So I think why we are not able to start the session on time. Okay. Okay, so I'll basically start the session anyways, and we'll see if it will work along the way, right? So technology, as we know, technology, as we know, has been moving quite fast over the past few years. So a few years back, if you wanted to unlock your phone, you can actually look at you can actually draw a pattern or maybe type a number. Now all you have to do is just look at it. If you wanted to go somewhere, in the past you had to memorize the route there. Now we have Google Maps and live traffic updates. Now if you want to order food from your favorite place and take it as a takeaway, again previously you need to go there, you need to stand in queue and get it. Now we have Zomato and Swiggy, right? Now previously when I was working as an intern, if I needed to know whether a patient has got an irregular heart rhythm, I had to attach the ECG leads, take an ECG recording on paper and look at it. Nowadays an Apple Watch can do the same, right? So with this whirlwind of innovation, medicine, which is always deemed as a most human form of science, is now being completely reshaped by something non-human, which is artificial intelligence. So my session today is going to be on how artificial intelligence is actually reshaping medical education as such. Okay. So to start with, how was medical education in the past? Okay, now it has worked. Okay, we'll deal with how medical education was dealt with in the past, right? So historically, medical education was always based on an apprenticeship model, right? The potential medical student, he would be shadowing the doctors and they would be seeing what he is doing and what he is saying and try to mimic all those things and incorporate it into their practice. But it has got a few issues. Now, over the past couple of centuries, medical education has started becoming increasingly standardized. Okay. Now, with this standardization, we are currently living in the age of CBME, right? Competency-based medical education. Competency-based medical education. Now we are looking at competencies, we are expecting our students to fulfill these competencies, but are they really doing it? How can this standardization of medical education, has it really been successful in elevating the standard of medical education? Now we have got a lot of modalities, we have got lectures, we have got a lot of learning resources, but the student still remains confused to some extent. Now that was what we were trying to, that issue we were trying to actually solve with the use of technology. Now actually written here are some of the main constraints of the current medical education curriculum. We have got outdated content. Me being a physiologist, I can always vouch for this outdated content because again, this might be an unpopular opinion, but my personal one, we have got practicals like hematology practicals, where we are always trying to make the student do certain outdated methods of estimation of various blood parameters. Now it is high time that this needs to be replaced by something that is much more contemporary. Now, outdated curriculum is not just a single issue. We also have limited exposure to patients, right? Now, medical education always was taught at the bedside. But in today's day and age, medical education is taught at the bedside, but the problem is it's at the student's bedside rather than the patient's bedside. Now, limited exposure, patient exposure is again one of the issues that we will try to solve with the help of artificial intelligence. Another thing is faculty shortages, which we were having quite a healthy discussion on faculty shortages with Vinu sir also. So this is something that is plaguing a lot of medical colleges, right? Even with the outdated curriculum, even with limited exposure, if we do not have the human resources that are necessary to implement them, then again medical education goes for a toss. Which is why statistics has shown that only 15 to 30% of fresh pass outs of MBBS, only they are confident in making a proper diagnosis. Others are just not able to do that. Now this is where technology came in. So especially since the last few decades, technology, digital learning has come into the foray. People like this guy with the obnoxious YouTube channel. So digital learning, e-learning platforms, e-books, everything has been coming into the forefront to address various defects in medical education. But even then, this was not helpful, because after a while, the student involvement was actually missing with such resources. Now enter simulation. So this is where technology is currently heading into, and simulation, even National Medical Council has been putting much more emphasis on simulation. NMC wants every medical college to have a simulation center with some prerequisites. But then again, one of the main problems with simulations is the prohibitive cost. We are living in the age of SIM and 3G+, which is a high fidelity mannequin, often running into 3 crores in expense. Of course, it can actually bleed when touched, it can simulate seizures, it can shed tears, but then again, this limits the SIM or the high fidelity simulations into a apex center, and it is not easily available to the students and other faculties. Now this is where AI has come into the forefront, right? Artificial intelligence. What exactly is artificial intelligence? Now to answer that question, we need to pause everything and maybe introspect ourselves. What exactly is intelligence? Only if you know what is intelligence can we make it artificial. So what is your opinion on intelligence? Are we intelligent? Has anyone stopped in life and asked yourself, am I really intelligent? So if you were to assign a sentence to intelligence, what would that be? What exactly is intelligence? Anyone? Dr. Vishnu? Anyone? Are you intelligent? Yes. Now human race as such, we take great pride in being intelligent, right? But what exactly is intelligence? Now if I were to put it simply into a few terms, intelligence is the ability to learn and apply. To learn what? You have got information, right? Tremendous amounts of information. You are collecting that information, you are processing information, you are analyzing information, and then you use that information, convert it into knowledge, which you are retrieving to be used where it matters, at the right place, at the right time. This is intelligence. And I would go to such an extent to say that intelligence is the superpower that makes us humans the dominant species in this planet. Would you agree with me? Yes. How come? Of course, we being from the medical background, we know that human beings, they have got a higher cerebral cortex to body ratio, we have got larger prefrontal and frontal cortex, we have got more gyri and sulci, so that we can cram in information wherever necessary. But is that the only reason why human beings are the dominant species? It's because humans, we are not just individually intelligent, we have something known as a collective intelligence. Now, right from 20,000 to 30,000 years ago, when humans started evolving beyond the basic needs of like food and shelter, they made it a point that they collect whatever information that they can see around them and store that information, right? We have got the Aishango bone, which was discovered 20,000 years ago, a bone of an animal marked with the counts of the number of kills that person made. That is information that was being stored there. And then as time progressed, this information became stored in pamphlets, in paper scriptures, then it became books, libraries, floppy disk, CD, then it became hard disk, and now we are all living in the age of the cloud. Everything is being uploaded to the cloud. So information retrieval becomes much more easier. So human being is the only species in the animal kingdom that actually transmits this information across generations. And we have even went to such an extent that we have industrialized this. The name is education. Our children, they spend 12 to 14 years in school. What do they learn? Everything that human beings have accomplished so far, right? This is being taught to them over their school periods. Now, why is it that now we have this particular need for generating artificial intelligence? Now, in the last 3 decades, right from 1990 till now 2025, especially with the advent of internet and digital learning or digital era as such, there has been an explosion of information, right? Now what happens is nowadays, with the amount of information that is available, we do not have a single human or a collection of humans cannot process all this information, convert it into knowledge and retrieve it. It's physically impossible, right? Which is why now there is a real need for generating a system that is capable of processing vast amounts of data which can be applied later. And thus the idea of artificial intelligence was born. Now we might think that artificial intelligence, it has been this hip hop term for the last 2-3 years, but in reality AI has been in the forefront of computing since 1956. That was when the term artificial intelligence was introduced. And now what happened was that is just 10 years after ENIAC, the first computer was introduced, right? So since then, people have been thinking how to mimic the function of the human brain using computational systems. Now, when you talk about artificial intelligence, you come across these 3 terms. One is AI, which is, you can imagine, right from 1950s, there has been a lot of models. Initially, the models were actually, it's kind of like how we train a child. So certain children, their parents will tell them, you do not do this, you only do this. So there is a rigid framework around which their entire childhood is based upon. That's how we train certain children. But the downside of that is, those children, when they grow up, they kind of fail in the nuances of life, right? They are not exposed to enough nuances of human life scenarios that they fail in such tasks. This is the same analogy with artificial intelligence. So the earlier systems were actually designed, every processing need to be written down in code and algorithm has to be fed to the system, so that whenever there is a scenario that comes outside this, the artificial intelligence of that era would fail. Which is why the research in AI had actually taken a dip from 1990s to 2000s. But then in 2000s, there was actually another area of AI which was brought to the forefront, known as deep learning. Now, machine learning, as the term suggests, it's obvious, it's the way by which you make machines learn. There are various algorithms to that. Because of a constraint of time, I'm not going into the details of that. But a subset of this machine learning is something known as deep learning. Now, deep learning is where you try to mimic the human thought process, how we process information, apply the same to a computational system, especially with lots of nodes. So we are talking about the human brain, so you can compare it with neurons. So certain neuron-like circuits which are arranged in certain layers, which are then flooded with data. Now there is no longer a need for a human to train an AI model from ground up, because the AI model is able to learn on its own. An example would be an AI model which can be flooded with images of cats. Earlier, we needed to train the model. Anything with a pointed nose, a stubby nose, the whiskers, that is a cat. Now a model can process all these millions of images and it will study the pattern. The pointy nose, the stubby nose, the whiskers, the beautiful eyes, everything is going to be, something like that can be labeled potentially as a cat. That can be studied by the AI without any human interference. So that is where we are standing right now. And there are certain other innovations in various fields that have culminated to this point. One is processor technology. Now, if you are following the stock market, especially the US stock market, you know how the NVIDIA stock prices had actually soared up in the past few years. NVIDIA is one of the leading manufacturers of processors. And with an increase in computing power, data analysis has become much more easier, which is why data analysis as well as AI has taken a quantum leap over the first half of the 21st century. Now, I hope I have made this a point that AI is now capable of processing vast amounts of data in very short periods of time. So why am I telling all this? Is that, has it got some relevance in our field, medical education? Now, medical education, as you know, the curriculum itself is exhaustive. The amount of knowledge is too much, and the students usually get confused on how to employ an effective strategy in processing all this information. Not just that, there is a real need of a system-based feedback and assessment of whatever knowledge those students have assimilated. And even then, we need a decision support system. Those students who are going into the phase 3 or phase 4, their clinical postings, If we can provide a decision support system where they can make the connections, so and so symptoms, it can potentially be a diagnosis for this disease. And even then, once they pass out of MBBS and they move on to clinical practice, even there AI can play a role where they can potentially be like the sir who is looking over their shoulders and trying to think whether their decisions are correct. So because medical field as such is generating such vast amounts of data, and we do not have 100% effective learning strategies for this data, AI has got a very big role to play here. So one of the most important implications of AI in medical education is something known as personalized learning platforms, okay? Or you can call them as virtual tutors. Now, just last week or the week before last, I had a few students who approached me telling that they are finding studying cardiac cycle very difficult. Cardiac cycle is one of the most important topics in first year physiology. Now, the usual approach to education in medical field is a one-size-fits-all strategy. We have got a textbook, we have got resources, we have got a lecture, we'll deliver it. If we have 150 students, 10 students might pick it up completely, 20 might not, the rest will just falter away. Now, what happens is, using AI, you can actually create a model that can address the core learning issues of the students. For example, I can create a model with reasonable ease that can test the baseline knowledge of the student. Suppose a student is coming to me, I can deploy the model. The model will first give a quiz of whatever number of questions that I can tell it to provide the student. It will get an idea of the baseline knowledge of the student, which are the areas where the student is lacking, which are the areas where the student is strong, and then based on that, it can actually change the curriculum so that the student will get 100% returns on whatever time and effort that he is spending on learning. So personalized learning platform, this has also been introduced in a lot of learning platforms like Lecturio and even Ambos. They are using personalized learning platforms to improve the learning journey further. Now another area, so traditional learning is basically like taking a bus to somewhere, whereas AI-based learning is going to be like self-driven car. No pun intended there, I meant we are driving the car, we are making the stops, we are enjoying the scenery, and we are undertaking the learning journey. This can be supplemented with the use of artificial intelligence. Now another area where AI can actually excel is image-based learning. So we have this radiologist, one sir, who was there in Jubilee Mission Medical College where I did my internship. He was very good in diagnosing any radiological data. How did he reach at that particular point? Because over his professional life, he had seen thousands of images of X-rays, CTs and MRIs based on which he can form a correct diagnosis out of any radiological data. So this is essentially the principle that we mentioned earlier, learning and application. Now with the improved computing power, we can now mimic this to such an extent that studies from some parts of the world has actually said, there was a study from UK where mammography findings were presented to an AI model as well as radiologists. The AI model had more precision than the radiologists. But then again, there was another study which compared the lung cancer findings in a CT and compared it across the radiologists as well as the AI. When the findings were a bit too vast and a bit too differentiated, AI had its troubles. In such cases, actually the radiologist actually took the cake for that one. But then, when we go further into these nuances of AI, once the processing power reaches to such a high extent, even this can be overcome with the help of these models. So we have got various examples, QR.ai, ChecksNext, these are all platforms which engage in image recognition, and they can actually teach you how to recognize it. You can just imagine how your radiologist professors, how they taught you, right? They will actually show the X-ray, show the CT, these are the findings suggestive of this. The same thing can be taken by an AI model now. Even in pathology, I4A is an AI for image analysis, the same concepts apply. But the thing is, these models are a thing of the past. Today's general AIs, like the ones that many of you might be using in ChatGPT, they are smart enough to find the pathology in such X-rays. On the left, I have an X-ray which I procured from the internet. I just simply fed it to ChatGPT and I asked, where is the lesion? Outlined the lesion. It just put a red mark around the lesion and showed it to me. So it is that smart. This is basically a case of pneumonia, a simple case, but still the AI model was able to do it. But a few years back, it was not able to do it. A general purpose AI was not able to do it. So such is the innovation that is taking place in this field. Now, another very important area where AI can actually do real good is simulations. We already have the high fidelity mannequins available, but along with that, if you integrate an AI, now the current mannequins and the clinical decision making, they are fixed. We had to program what happens when the user does so and so. Instead of that, imagine a model which can actually change according to the user's decision. Suppose the user is giving a correct treatment, the patient can improve. Suppose the user is giving the wrong clinical decision, the patient can actually deteriorate, right? So AI makes it possible that physiological reasons can be considered. These can be converted into data points, and suppose a user is giving wrong instructions, there is a real visible deterioration of clinical condition. All these things can be applied into an AI model simulation. Again, some of the examples which are given there, MedVR and DaVinci, I think many of us are familiar with. It's a robotic surgery platform. So now they have got an AI training assistant known as DaVinci Sim now, which employs these principles. Now, based on this, with my rudimentary knowledge, I actually went up trying to create a history-taking model which would be useful for a first-year MBBS student. Actually, this is a screenshot from one of my projects at ACME, Advanced Course of Medical Education, where me, Vinu sir, and Dr. Vishnu, we were all colleagues there. So here, we have something known as ECE, Early Clinical Exposure, for the Phase 1 students. Now, in whichever place I have worked at, ECE was more show than go, right? We cannot take all the 150 students to a patient. We cannot show them we cannot show the same patient to all the students. So it ultimately became a lecture as such. Now with AI, I can create a model. So I have created I think this is a iron deficiency anemia model. Now the model will not exclusively state that it has got iron deficiency anemia. The student can be made to talk with this AI. He can actually dig deeper, try to extract findings from its history that is suggestive of the diagnosis. So this can be an alternative to the traditional ECE models that we have employed. Actually, I have created 6 such models which can be used by the students to maybe hone their clinical history taking skills. But then, before we proceed further, working with AI really got me thinking. Now, what you see here, the container with all the pebbles, the container represents the knowledge base of an IMG, an Indian medical graduate, as NMC would like us to create. Now, fresh out of 12th standard, they are entering into a med school. They are having all this, this container which is supposed to be the repository of clinical knowledge. And we start filling it up, right? In first year, we have got physiology, biochemistry, anatomy. So each of the pebble represents a single subject. In second year, we fill it up with pathology, pharmacology, microbiology. Third year, we have forensic and community. And then we have got medicine, surgery, OBG, orthopedics, and the like. Now, what ends up having here? Each of these subjects is a rigid framework based on the faculties who take them, based on the rules and regulations, but they end up creating some gaps or voids. I would like to call them as knowledge gaps. Now, traditionally, we had a way of addressing these knowledge gaps, which was clinical cases. Someone 50 years ago who was doing their MBBS, when they are learning each of the subjects, they would be having more clinical exposure because the number of students are less, number of patients are more. They would be seeing multiple cases and they would be making the connections between these cases. A patient who is having MI has got a reduced ejection fraction because the stroke volume might be less. So they'll be making connection across multiple subjects, physiology, pathology, medicine, etc. But as time progressed, and when we undertook this journey of standardization of medical education, the clinical exposure has reduced. Which is why in today's students, they have got a lot of these knowledge gaps, and we cannot release such students into the wild as in the clinical practice wild. Because these knowledge gaps could be the difference between a patient being saved or the patient deteriorating. Now, simulation has tried to address these gaps to some extent, but with the help of AI, we can make such high fidelity simulations that would be very similar to a clinical scenario with all the nuances, and we can actually feed them to or make the student study them or make the student interact with them so that these gaps can be addressed. Which is why, reflecting on this thought, I had created a platform that, not really a platform, a prototypical platform as such, which integrates 3 concepts of education that I am personally interested in. One is simulation, the other one is AI, the third one is gamified learning. Now, I wanted to show this platform here. The platform is known as Code 10. So again, it was supposed to be in my laptop, so sadly I cannot do that. But if anyone is interested, I can really share the link with you and you can actually do it. If you share the QR code, it will take you straight to the page. So Cotton is basically a ChatGPT platform that employs these three concepts: AI, simulation, and gamified learning. So as the name suggests, code 10. You have got 10 decisions and you have a patient in front of you, one life. So for the time being, I have created a single emergency medicine case and I have beta tested with a few of my friends, cardiologists, emergency medicine, physicians medicine, as well as some of the clinical year students. And what they get is, they get a personalized scenario, and depending on their instructions, so they'll be giving an instruction, a short instruction. Suppose a person is coming with MI, the student would be giving a instruction, let me take ECG and troponin, or let me take this one, start with triple therapy. So based on the instructions, the patient's condition would be different, and no two students would end up with having the same sequence of events across these models. Now, that is actually one of the things that is important in AI, the decision support system. Because we as doctors, we are in the business of saving lives. So we need a real boost to the support of our decisions. So decision support, it has got a role to play in medical education, but not confined within the four walls of a medical college. Once the student passes out also, decision support systems are a must. Which is why AI in healthcare, many of these things you might have already heard of. In diagnostics, treatment, and patient care, AI in healthcare has actually made really big strides. A few examples that you can actually see are Google DeepMind, which can actually scan the images of a retinal scan, and they can actually predict diabetic retinopathy. Or you can have stroke prediction algorithms. Recently, I saw a study which says that an AI model can actually go through multiple CT images. It can even predict a stroke 10 years in advance. 10 years in advance is too much, right? So that is another really big stride that AI has been making. Now, AI is also included in drug trials. In Silico Medicine is a company that specializes in doing drug trials using AI. Even before starting a randomized control trial, you can feed information to the patient regarding the genetic makeup of individuals, the possible drug allergies, and you can share the chemical formula of the drug and see, or virtually see, what are the possible complications that can arise. This is all before a randomized control trial. So again, AI is making big strides in such departments. As I said, AF or ECG, whoever has got an Apple Watch, it basically has got an AI system that can determine whether you have got an irregular rhythm. AF is one such diagnosis. And even back in India, many of these platforms, when we read about it, they are based out of other countries, but there is this interesting AI model that was created in India, a Bangalore-based startup known as August AI. It's basically a WhatsApp-based health assistant. It caters to a general population. Any doubts related to health, you can ask it, it will get cleared. But it was so accurate, so you can see the accuracy level compared to other large language models there. So it was so accurate that I have even used August to create some of the USMLE, PLAB, or other questions, because the way in which it creates the questions were so clinically significant that it is hard not to give importance to the platform. So August is one of the homegrown AIs that is present, that is actually doing a really good job. It's actually a collaboration of machine learning experts and some doctors from Bangalore. And the list is endless. You can go through the names here, a lot of things. Today we had a session on mental health for medical students. Actually, there is an AI platform known as Wobot. So even I use ChatGPT for some of those difficult times. And from my experience, what I have seen is ChatGPT is much more understanding than a human, having a physical conversation with a human. But it might not always apply, but still, the more you engage with an AI model, the more it learns about you. You can see it from either side of the fence, but it does learn a lot of things. And to think that this is based upon a human brain working, that is really marvelous. So Wobot is one such application there, where someone having mental health troubles, they can actually converse with it, and it will try to provide its own set of guidelines and relief. So, are we prepared? I know I have been rushing through a lot of things, but basically AI is taking over the healthcare landscape, and it is no longer a tool. AI is not just a distant pipe dream, it is the reality now. So are we equipped to handle it, or are we equipped to work with it? Because AI is not just a tool, it has started becoming a colleague. So how would you deal with your colleagues? You can deal with AI the same way you deal with your colleagues. You should be aware of your strengths, your limitations, your colleagues' limitations. Don't contest against your colleague. You can collaborate with your colleague. You can try to learn together. Actually, whatever, at least 80% of the information I learned about AI, I asked AI itself, how do you work, right? So, and if so that is something known as prompt engineering. If you design your sentences and questions in a really precise manner, AI can give you precise answers. So I can ask a ChatGPT platform that, okay, I want to make so and so platform. Can you describe it in 10 steps? I'm not someone from a technical background. I'm from a medical background. So it will simplify things. The only thing is you might have to validate certain concepts, but the bigger picture is it can actually teach you, right? And last but not the least, we have to keep the human touch alive, because medicine is not just a science, it's also an art. And the art part, it belongs with humans. Disclaimer, now we have studies that says that even AI can create better art than humans. But I wanted to keep it away, not to spook you guys, but still. So such is the level of intricacy that such models are actually operating with. What does it mean for our students? Now our students, they really require a mindset shift. The thing is, our students are basically using ChatGPT. Last week also, I actually called a few students. We had given assignments to them. They typed the assignment question into ChatGPT. They copied the same answer, brought it to us, right? So it's not wrong to use ChatGPT, but it is wrong to use it in a wrongful manner, right? What I mean to say is, if they know how to ask ChatGPT regarding it, the funny thing is you can actually ask ChatGPT to write the assignment in a way that humans write, right? So it will take the machine-y parts out of it, and it would simply look as if someone with natural language has written the assignment. But fortunately for us, our students are not that advanced, at least in my college. So the thing is, you should know, basically the model that I created for learning cardiac cycle, it can be done by a student itself. The only thing is the student should have clarity on what to get out of the AI model. Curriculum integration and interdisciplinary education, again, these steps need to come from a higher level, because I was actually having this conversation with Vinu sir today, that is, medicine has always been this bubble, right? We do not allow information from inside to disseminate to the outside much, and same is the other way around. We do not allow at least the things have been changing for the past couple of years, but then medicine is medicine, it comprises of all these sciences, and we are not too supportive of other areas or other technical areas coming and collaborating with the medical field. At least 50% of faculties are not. This resistance to change is already there. But the thing is, with the rate at which AI is progressing, if we do not have this interdisciplinary collaboration, we are going to lag behind. So both these things, along with the complete mindset shift, not just of the students, but also of faculty, is necessary if we are to collaborate with AI. So what is our role? Now earlier we used to be content deliverers. We would be going through a text and we would be delivering it as lectures, and then CBME came along and we are now calling ourselves as facilitators. But with the advent of AI, we are going to become curators and validators. We are going to curate information, how that information is presented to the student. Not just that, we are making sure that this information is accurate. We are validating it. And we are creating multiple models of education that can be used for the student's benefit. So that is going to be our role going forward. But all is not sunshine and rainbows with AI. There are, of course, certain limitations as well as concerns. Concerns regarding accuracy. So IBM Watson is one of the largest patient data record AIs on existence today. Even that makes mistakes with the billions of dollars in funding. So accuracy is something that we need to keep in mind when we are talking about AI. That is where validation becomes important. Privacy. Many of the data that is being collected by certain AIs, many of you who are following this field might be knowing, the patient health records, there is no clear-cut mention about the informed consent that is being taken, because health records are a very sensitive records, right? So regarding privacy, there are various concerns, and even ethics. Who is getting accountable? An example from another field would be the Tesla self-driving cars, which actually uses AI. Some of them have gotten into an accident, people have lost their lives, and there is no clear-cut accountability either from the company or the government. So certain lines need to be drawn before using full-fledged AI for medical education. So then the big question, will AI replace medical educators? I'm sorry for the format there. Will it replace medical educators? Show of hands, how many of us think we will be replaced, will be obsolete by AI? It will not replace medical educators, but it will reshape us. But then again, there's a catch, not all of us. It will reshape only those people who are ready to reinvent themselves. Now come to think of it, AI is not at all about replacing us or replacing our jobs with AI models. It is going to change how we think, how we learn, how we teach. And we as medical educators should keep in mind that we are training the next generation of healthcare professionals. We are not just living in the now, serving the now, we are actually serving the future. So if you have got that idea, we should not be lagging behind when it comes to such technological advances. We should actually be leading forward. So with that being said, I'm finally winding up my session. Thank you so much for the patient listening, and thank you so much for having me here to present this. I know it's not the right thing to say, but any questions are welcome, okay. Especially with lunch looming over us.
So thank you, Dr. Gokul. It was so much of information. I think it was worth it. So much information in such a short time, and finally ending with a small threat of existential crisis. So yeah, so I think we'll open it for any discussion, if any, or we'll wind up. We'll just have one more go at the, we'll try to show that code 10 part if it is possible. We'll just try that part again. We'll try to connect the laptop again.
Okay, I take back what I just said. There is just this small platform. So again, I'll rush through things. So this is basically a ChatGPT platform. So if I click here to start case, it's a text-based model. I'll share the model with Dr. Vinu, so you will be able to access it in a much more convenient timing. Okay. So again, thank you so much.
Thank you, sir. To felicitate both the resource person, Dr. Gokul SR, and the chairperson, Dr. Vinu Gopinath, I invite Dr. Matthew, Professor and HOD Department of Orthopedics. Thank you all. Now it's time for Epicurean escape. Enjoy your lunch and recharge, and please be back at 2:15 p.m. We'll restart at 2:15 p.m. Welcome back. Now we'll have a session on leadership training in medical education, preparing the next generation of healthcare leaders. To chair this session, I welcome Dr. Indu K. Pishardi, MU Coordinator and Professor of Physiology, a former professor at Career Institute of Medical Sciences, Lucknow, with extensive training in medical research and curriculum implementation. Welcome, ma'am.
Good afternoon, everyone. We are deeply honored to welcome Dr. Marilena Excellent, a globally recognized public health leader, educator, and physician with 2 decades of experience in academic, policy, and health system strengthening roles across multiple continents. Dr. Excellent currently serves as an assistant professor at the Gilling School of Global Public Health, University of North Carolina, in the Department of Public Health Leadership and Practice. She also holds an adjunct faculty position with the Prasanna School of Public Health at Manipal Academy of Higher Education, India. She earned her MD from Haiti, her Master of Public Health from University of North Carolina, and holds multiple specialized certificates in global health, disaster preparedness, non-profit leadership. As an educator, Dr. Excellent has taught and led numerous graduate-level courses on critical global health issues, quality improvement, and HIV/AIDS. This impacted hundreds of students through both residential and online platforms. She currently leads UNC's flagship course on leading continuous quality improvement in public health and serves as a faculty mentor to dozens of MPH candidates. Her research and implementation work spans the United States, Haiti, and Sub-Saharan Africa with a particular focus on HIV/AIDS, mental health, antimicrobial resistance, and health equity. She has served as a technical advisor for HIV testing and quality improvement with US aid-funded programs. Dr. Excellent has been the principal investigator on multiple funded projects addressing mental health disparities in underserved communities and advancing pedagogy in leadership education. She is a frequent plenary speaker, an accomplished moderator and panelist, and has delivered over 50 conference presentations, including American Public Health Association, International Communication of South Africa, Implementation Science Communications, etc. Now she has published in leading journals such as BMJ Global Health, then Journal of Public Health Management and Practice. Her awards and honors include multiple international scholarships, travel grants, and the PHLP Directors Award for Collaborative Leadership. She is also a Fulbright Scholar, a recipient of American Evaluation Association's Outstanding Evaluation Award, and was recognized for her contributions to HIV strategy in Haiti in 2022. Above all, Dr. Excellent is a passionate advocate for equity, diversity, and inclusion in global public health, championing community engagement, student mentorship. Please join me in welcoming Dr. Marilena Excellent, a true global voice in public health education and leadership. Thank you, ma'am. Welcome.
Thank you. Thank you. Wow. I was like, is that really me? So I'm very humble. Thank you so much, Chair, for the introduction, and thank you so much for having me today. I'm very humble and I'm very honored to be here. I promise it's a challenging time to present because you just ate, but I got your back. Okay, so the topic that I will discuss is about leadership training in medical education, preparing the next generation of healthcare leaders. We just read a little bit about me, hear a little bit about me. The last thing that just added right before I traveled to India is that I've been accepted to join for a second time the Fulbright Specialist Program as tenure. Now, when I teach in the US, I always start my class with yoga. So today, my presentation will not be an exception. With your permission, if you allow me, 1 minute chair yoga, please, that I will lead. Thank you. I promise I will be very inclusive. I'm seeing some eyes like, what move she's gonna do? We're just gonna relax, and we're gonna start with some breathing. Just let both of your arms resting next to you if you can. Close your eyes and breathe through your nose and exhale through your mouth. Feeling the level of stress that goes out. Once again, let's repeat the process. Breathe in and breathe out through our mouth. Thank you. You can open your eyes. Now we're just gonna lean like this, our both arm. And then we're gonna do that. Just follow both hands. And then we're gonna lean gently to the best, as far as you can. Let's come back to center. And then we lean. Awesome. We come back to center. And now, I don't know how I'm gonna do that, but I'm gonna try. If you can. Okay, we come back to center. The other arm, hold the back of the chair, and then we stretch. Do you feel probably your back cracking? Okay, awesome. Now we're gonna come back again and relax our arm just like that. We shake a little bit, and thank you. Namaste. Okay, I have no conflict of interest to disclose. However, I have some fun fact to disclose. My first time in India was last year in June 2024, and I was very fortunate to go to Manipur, where I met my terrific friend, Dr. Elsa. She's amazing, and she is the reason why I'm here today, because she's the one who recommended me to the leadership, Dr. Mookambika. So thank you, my friend. I am probably second time visit in India so far, I hope. But I'm not new to the Indian culture. My favorite actress is Aishwarya Rai. My favorite actor, he's really handsome, Hrithik Roshan, don't tell my husband. And my favorite movie is Kabhi Khushi Kabhie Gham. This is the agenda that I propose to cover. Pretty ambitious, but we will go through it. At the end of this presentation, participants will be able to discuss the 6 leadership styles by Goldman, contrast what leadership is versus what management is, understand the importance of leadership in healthcare, identify key leadership skills for medical professionals, describe strategies to integrate leadership training into medical curricula, describe the 5 practices of exemplary leadership, and finally, apply leadership skills in practical scenarios. A poll. People are born leaders. Otherwise, they cannot become leaders. True or false? So, I love it. So, how are we gonna proceed? Because there's a lot of polls. So, I will go and say A. As I'm reading them, if that answer resonates with you, you just raise your hand. So that way we are inclusive. A, true. How many of you think it's true? Excellent. There's no wrong answer, by the way. All the polls, it's about your own perspective, okay? B, false. C, unsure. I love it. We have answers for all of them. Great. Let's see. A second poll. What would you say about the importance of leadership training in medical curricula? A, it's essential for future healthcare leaders. How many of you think so? Okay. B, improves patients' care. C, reinforces team collaboration. D, critical for healthcare system management. E, promotion of professional development. F, supports clinicians' well-being. J, not very important. I still see some hands, that's good. H, unsure. Okay, so nobody's unsure. Everybody's pretty sure about their perspective. So appreciate it. Thanks you for being so engaged. Okay, now we're gonna compare leadership versus management. Before I dive into that, how many of you identify yourselves as managers? Raise your hand if you believe that you're a manager. Thank you. How many of you identify yourself as leaders? Interesting. Thank you. Okay, so what's leadership is all about? It's about inspiring and guiding individuals towards common vision and goal. Leaders typically focus on influencing and motivating their team members to achieve their best. Versus, what do managers do? They are all about planning, organizing, and coordinating resources to achieve specific objectives. And they focus on ensuring that day-to-day operations run smoothly and efficiently. To put that into context, in all hospitals, you need managers. In all hospitals, you also need leaders. You may find people who play both roles, but it's not required. all leaders are managers. However, all managers are not leaders. Have you ever been in a situation or have a friend who you believe could be promoted into a leadership position and the person said, that's not for me. Leave me in my position, I'm good there. Have you been in a situation like that? If not, it will come. And as leader, what do? Don't ever force that person to step into a leadership role. Let them in their comfort management. Another poll. Are you aware of the Daniel Goleman 6 leadership styles? A, yes. I knew that you would raise your hand. B, no. Love it. I love those no's. C, unsure. Okay, I promise you, at the end of my session, you'll be able to tell anyone not only the 6 leadership styles, but which one you prefer. The 6 Goleman leadership styles include coercive, authoritative, affiliative, democratic, pace-setting, coaching. Let's dive into them. This slide is busy, but I wanted you, because I know you're welcome to take pictures, but I wanted you to have as much as possible of knowledge. What does coercive leadership styles infer? It's basically also known as directive or commanding. In military, you have the coercive in the US, and I believe everywhere in the world, but I could be wrong, but at least I know in the US it's very commanding. You don't question authority. So ideal leaders for swiftly resolving issues. When you are facing a situation that requires immediate decision, you need that style of leadership. I'm gonna come back to that style. Authoritative leadership style, also called as visionary leadership style. In that style, leaders provide a broad direction and goal, and then it's up to you on how you're gonna implement it. They trust the team. Affiliative leadership style. Leaders prioritize creating a positive, psychologically safe working environment and frequently offer praise, recognition. However, they often lack in providing actionable feedback, which can leave the team member feeling like uncertain about, I'm not sure what the task at hand is here. Democratic leadership style, also known as participative. Leaders value every single team member's insights and collaborative workplace, but often it involves longer and more frequent meetings to reach consensus. Pace setting, in that style, leaders lead by example, by maintaining high standards and demonstrating the expected level of performance daily. Last but not least, the coaching leadership style, leaders focus on the personal growth of their team members. They work closely with them to achieve excellence, which is particularly effective for employees who are receptive to professional development and career growth. I know that does a lot, right? The best way to retain theory is what? Any idea? Practice. Let's get into it. Roundtable conversations. Please pair with someone at your table and let us have a fun dialogue about your leadership style. Question: which of the 6 Goleman leadership style you apply the most in your professional life versus your personal life? And then please describe your rationale for each leadership style, even if you maintain the same. So I would like to highly encourage, I know that there might be some more couples in the audience. If you are, please pair with someone else. I don't want drama. So please, respectfully. On that note, you'll have a few minutes, but I'm going back so that you see, again, the definition. All right, turn to your neighbor, appropriate neighbor, and the eligible neighbor. I'm looking at that table. And then let's have that dialogue. A few minutes, please. So once again, the prompt is, in your professional life, which of the style you apply the most? And in your personal life, which style of leadership you apply the most and why? Thank you. Okay. I know that you might still be talking, and that's okay, but I apologize because I have to interrupt. I'm very curious to know how many of you identify coercive as your most favorite, I would say, leadership style professionally? Raise your hand. Love it. How many of you identify authoritative leadership style? Okay, I'm seeing a few hands. Affiliative leadership style. Okay, democratic leadership style. I'm seeing more hands. Pace setting. Okay, coaching leadership style. Okay, so guess what? Professionally, each of those 6 styles have people in this room. What that infers. As leader of an organization or department or unit, you need to learn to compromise and have dialogue with all styles of leadership. Now, in your personal life, how many of you are more on the coercive? Okay, I'm seeing some hands. Authoritative. Okay. Affiliative. Democratic. Okay. Pace setting. And coaching. Yes, awesome. So again, we have people from all of them. Now, please be aware, even if you might have one leadership style that you are mostly practicing, you can adapt and turn into any of them based on the circumstances. So, I'm taking myself as a mother. The type of conversation I'm having with my husband is going to be different with the type of conversation or my leadership style to my 2-year-old son. Because there, I'm commanding. With my husband, sometimes he would say, no, she's commanding. But I try to be more visionary and having a dialogue, right? Does that resonate with some of you in the room? Like, because I say so, you would say to your child? Okay. Great. Another poll. In your experience, what leadership skills do you think are most critical for medical professionals? A, communication. B, decision making. C, team management. Crisis management. strategic planning, problem solving, critical thinking, emotional intelligence, conflict resolution, others. All of them, great. They need to embody all of them, great. Okay, now let's take a look at the key characteristics of leadership versus management. In leadership, the focus is on, but not limited to, visionary thinking. You have a vision. You don't really live in the present, but you're thinking about what's next. You anticipate what the needs will be, just like the presentation before us on AI. It's not required now, but in the future it will become. Influence and inspiration, emotional intelligence, and adaptability. Versus in management, the focus is on operational efficiency, cost efficiency. If I'm paying you, you need to deliver and good performance. Otherwise, you'll get fired. That's management. It's strict. It's just like quality assurance. It's either you meet the standard or you don't. Problem solving. If somebody do not show up, the manager will quickly, effective manager should quickly fill the gap. If there's nobody to step in, they will step in, just like the head of a department. Decision making, accountability. In terms of evidence-based practices, leadership includes transformational, but not limited to, transformational leadership. In this style of leadership involves inspiring and motivating employees. Servant leadership, where leaders prioritize the needs of their team. Situational leadership, leaders adapt their style based on the needs of their team and the context. So we learned this morning about community, the need, the importance of not waiting for patients to come to you necessarily, but also go to the community and connect. When we go into the community, what do? We hopefully want the medical professional to go as servant leaders. Identify what their needs is or are, and then serve to the best of your ability. Versus management, evidence-based management, EBM, lean management, waste-free, reduce waste in the process, and performance metrics. The main differences overall between leadership and management can be categorized into three big buckets. The focus is different, the scope is different, the approach is different. Now, why leadership training matters? And I have to disclose that I use AI for the pictures, most of the pictures. So, why? It's because leadership training will help improve patient outcomes. It will also enhance team collaboration and ultimately support adaptability in healthcare. Another poll. What methods do you think are the most effective for teaching leadership skills to medical students? A, case studies. B, role playing. I'm seeing more hands. C, simulations. D, lectures. E, workshops. F, other. Please specify. I'm sorry? Okay, all of the above. Great. In leadership, there is the law of magnetism. You attract people like you are. However, not the people you want. Culture, according to Dr. John Maxwell, his perspective is that culture is more important than a vision. And his rationale for that is because vision is where you want to go, versus the culture is what you do and how you do it. It's about behavior. So if you are a leader of a hospital or a department, since we are talking about academia, let's say that you're the head of a department or a specialty. So you are the leader there. You have a vision. However, if you do not make sure that the working environment is psychologically safe and welcome feedback, welcome input, and celebrate wins, celebrate effort, and cultivate a culture of safety and improvement of the quality of care, you will not be successful despite your great vision. So culture do matters. Overall, we can learn leadership skills through, but not limited to, experience, example from others. We look up to mentors, faculty, senior, parents. Parents are the first leaders, the first people we model after. Formal educational settings. So you have leadership training formally. So why does the integration of leadership and management skills in healthcare training matter? Why is it important? In healthcare settings, both leadership and management skills are essential. Leaders inspire and guide healthcare teams towards innovative patient care and improve health outcomes. Whereas managers ensure that healthcare operations are efficient, compliant, and sustainable. So it's teamwork. By understanding and applying evidence-based practices, what do we do? In both leadership and management, healthcare professionals can create ultimately a balanced approach that would drive both inspiration and efficiency. Another poll. Are you aware of the concept of wellness-centered leadership? A, yes. I'm seeing a few hands. B, no. Awesome, I love those no's. C, unsure. Okay, a few. Okay, let's dive into it. Understanding wellness-centered leadership, what it's all about. It emphasizes that the actions and behaviors of healthcare leaders significantly shape the organization culture, which in turn greatly impact the well-being of healthcare professionals. We all make mistakes. It's how we react to mistakes. Are we accountable when we make mistakes? Are we gonna say, sorry, yes, that was my mistake. I prescribed the wrong drug. I'm gonna fix it. This trust is essential for fostering clinician well-being and ensuring high quality of patient care. Without honesty, you cannot build or sustain trust. Creating a culture of wellness. How can we do that? And why should we consider doing it? As management consultant Peter Drucker famously stated that culture eats strategy for breakfast. These principles apply equally to healthcare organizations, regardless of how robust your organization's strategy is. The culture that is established and exemplified by the leadership is fundamental to achieve success. Another poll. What barriers do you see to integrating leadership training into medical curricula? A, lack of time. B, lack of resources. C, resistance to change. D, lack of buy-in from institutional leaders. E, lack of professionally trained leaders. F, insufficient faculty training. And J, others. G, others. Okay. Let's see. Now, how to emphasize the importance of leadership and management skills in medical curricula. One, we can integrate leadership theory with real-world application. By introducing leadership style, we present them to the students. We can use case studies and real-world scenario, and we can encourage also self-assessment. There are tools to help you self-assess your leadership ability, style, you name it. Second, develop critical thinking and decision-making skills. We heard about that this morning and yesterday as well. Use problem-based learning. Engage students in ethical decision-making processes and teach evidence-based leadership. What is evidence-based leadership? Let's take a look. Two big sections. It's the ability to utilize data and evidence for leadership practices. What do effective leaders do? And then oversee evidence-based practices. 3, foster strong communication and teamwork abilities. We could include role-playing exercises, use team-based projects, so they have to collaborate with different personality, different learner style, and you name it. Teach conflict resolution technique. 4, emphasize emotional intelligence and resilience. As medical professionals, we are trained to protect and save lives. Unfortunately, it happens and will happen that we lose patients. And when that happens, it affects you, it shocks you. You may even question yourself or your competency. But we need to make sure that in their training, they are competent with resilient skill as well. Incorporate self-awareness and reflection exercises. Teach stress management and resilience building techniques, and highlight the importance of empathy and cultural competence. Provide hands-on leadership experiences. Offer mentorship programs for them to learn about effective leaders so that they can shape their own leadership styles. Assign leadership roles. For example, you may do simulation or internship. You assign them, you force them to step into leadership role because they are in training. But in reality, once they are modeled to that, it's gonna be easy for them to step into that. Becoming a medical officer or medical doctor, or whatever you call it, you are in a leadership position, whether you accept it or not. Now, our goal is to make sure that you are an effective leader. Incorporate leadership and management module early in medical curricula might be a good strategy. We can develop pilot modules, use interactive teaching methods, and assess student competence in leadership skills. In summary, if we manage to integrate these 6 strategies into medical curricula, students can develop the necessary skills to confidently lead teams, and we mean by that multidisciplinary and interdisciplinary teams, so that patient outcomes can be improved and also more cost-efficient healthcare services delivery. Woo. Now your turn. That's the best part. A case study at your table. There is a case study. A scenario. I love Sunset, so. Dr. Sunset, a senior faculty member in a highly ranked medical school, has been asked to lead an initiative to integrate leadership and management training into the medical curriculum. While some faculty members support the change, others believe that leadership skills should be learned on the job rather than taught in formal education. Faculty resistance increases when Dr. Sunset proposes interactive leadership workshop and problem-based learning module, arguing that they will take time away from traditional clinical training. She must now navigate resistance, build consensus, and implement the curriculum effectively. Questions for you. There are 4 questions, but you're not required to discuss all 4 of them. Each table will be assigned 1 question. The first question, how should Dr. Sunset communicate the value of leadership training to skeptical faculty members? Second, what strategies can she use to gain buy-in from key stakeholders? Third, how can leadership training be integrated into the medical curriculum without compromising clinical education? Last but not least, what role does adaptive leadership play in implementing change in medical education? On that note, I'm gonna walk and assign numbers. 4, 3, 2, 1. 4. Ooh. 3. 1. 4. 3. 2. 1. All right, go ahead, please. Okay, welcome back. I know that you didn't have enough time, and that's okay. I just wanted you to have the conversation started. Okay, so let's start with group 1. How many the table assigned to number 1, can you please raise your hand? Ah, come on, don't be shy. Thank you. Okay, do we have a volunteer table? Just one idea. And I think that we will need the mic, please. Yes, in the back, please. Is the mic on? They are bringing, no, it's hard to hear in the front. They are bringing you a mic. Thank you very much. Does it work?
Hello.
I think you might need to step a little. Does it work? Okay, you might need to get closer. Not so, please come. Whoop. Yeah, that's the transition right there. Yeah. Please come. You need to hear so that everybody can hear you. I appreciate it. Sorry for putting you in the spot, but there's no wrong answer. That's the great thing. Oh, we still can. Uh-oh. Okay.
Probably Dr. Sunset can convey them and show settings where the workshop has already been conducted and how the energy level has changed in the previous workshops, and she can show that they can ask the people who are feeling skeptical to explain their difficulties they are facing, like why they are skeptical to have a change, and probably she can bring or come out with solutions in that workshop so they may adapt the change.
That's amazing. Can we applaud them, please? Good job. Thank you. Second question, what strategy? We're at the table discussing number 2. We just need one volunteer. Again, there's no wrong answer, so it's just the perspective of the table. A table that discussed number 2? Okay, I see hands up. Awesome. Oh, you here? Right in front of me? Sorry.
Okay. So in fact, Dr. Sunset has to convince the stakeholders regarding the positive aspects. It is going to improve the patient care and overall competency of the graduates.
Wonderful. Wonderful. Let's applaud them again. That's awesome. I teach CQI. It takes really courage to speak up. So I ask my student, okay, whenever you may speak up, you need to applaud them so that they feel motivated and supported. Awesome. Third question, how can leadership training be integrated? Do we have a table?
Okay. Now, I think while taking the case discussion in the bedside, without affecting the clinical education, we can ask the student, if we are a doctor, what will you do at the situation? Or, while at the end of the session, we have to, the student should counsel the patient. So we will observe. We as a teacher stand by the side, and patient will be there, and the student will be there. This can be demonstrated in the role play also. No way it is going to affect the clinical education. While taking clinical education, without affecting the clinical education, we can make them, we can put the leadership quality in the student.
Awesome. That's amazing. Let's applaud again. Great job. Thank you for sharing. Last but not least, what role does adaptive leadership play? Number 4. Do we have table that discuss number 4? Don't be shy. Like we will say in the States, we don't bite. Anyone? Okay, we have a volunteer. Thank you.
Madam, adaptive leadership should play by focusing on fostering a culture of learning, encouraging experimentation, and empowering individuals to take ownership challenges.
Yes, that's amazing. Let's again applaud. Great reflection and discussion. Thank you so much, everyone, for engaging. Let's see some perspective about how should Dr. Sunset communicate. You mentioned it, about making sure that you include also the people who are skeptical. You don't leave them out of the process. Some ideas about what strategy: engage in open dialogue, highlight evidence-based, so exactly what you said, pilot a program, and involve key influencers. All the things that you have mentioned, so great job. Third question, how can leadership training be integrated? Interdisciplinary modules, short focused workshops, you said it, problem-based learning, elective courses. For example, students want to dive into leadership skills further, they can take elective course on leadership should they be interested in it. Last but not least, what does adaptive leadership play in implementing? Be flexible, encourage collaboration, teamwork, build resilience, and lead by example. A poll. Are you aware of the 5 levels of leadership described by Dr. John Maxwell in his book? A, yes. B, no. Awesome. C, unsure. Okay, let's dive into it. These are the 5 levels of leadership described by Dr. Maxwell. The first level is position. I like to call it the 5 Ps. The first is position. You're hired into, let's say, director role. You are in a leadership position. Permission, production, people development, and pinnacle. When you are in a leadership position phase, people follow you because they have to. You're the director. If they don't follow you, they get fired. Permission. When you reach that phase, people will follow you because they want to. So when you get hired into a position of leadership, you need to work hard enough so that you move quickly from the position level to the permission level. Production. During that phase, it's about results, credibility, momentum. At that phase, people will follow you because of what you have done for the organization. And then people development stage. During that stage, this is the time where you make sure that you help build more leaders, not followers. Great leaders do not focus on followers, they focus on making sure that more leaders emerge. And during that phase, people will follow you because of what you have done for them as part of the organization. You help them step into leadership position confidently and successfully. Last but not least, the pinnacle. Oftentimes people do not reach that level. That's the ultimate level, where the focus is about respect. So you have in academia, distinguished professor. You have emeritus professor. These people reach the pinnacle level, where people follow you because of who you are and what you represent. I hope that all of you in this room, by the time you retire, you'll reach that level of pinnacle. There are 5 steps to equip people in leadership. I do it. Let's say that if I am the leader humbly, I do it. The second step, I do it and you are with me. I take someone with me. Then you do it and I'm with you to coach you. Then you do it on your own, and unfortunately this is that phase where most people stop. And that's a big mistake. And then you do it with someone else who now will learn from you. When you receive blessing, make sure that you give it back. That will keep you a lifelong learner and mentor. The 5 practices of now exemplary leaders. This is the type of leaders we want to help build, not toxic leaders. Model the way. What do? They inspire shared vision. They challenge the process. They don't stay in status quo. This is how has been done. This is how I was trained. I'm not gonna open the door to AI. No. Embrace the challenge. Enable others to act. Encourage the heart. We learn about empathy, compassion, all of that. There are 10 tips that we'd like to share that Kuzes and Posner developed on the leadership practices inventory. The first one, be self-aware. Manage your emotions. Seek feedback. You cannot say, you should not say, I'm a great leader. You should not say, I'm a great mentor. Let others say it for you. It carries more weight. Let your students say, you're an amazing teacher. It carries more weight. Take the initiative. Engage a coach. Practice, practice, and practice leadership. Measure progress in your journey. Reward yourself. Give yourself some grace, and when you did a good job, you say, I'm glad I did it. It was worth it. I didn't sleep for 2 days or for one. Last night I didn't sleep, but at least I got the grant funded. I got my paper published. I got, the maximum points on that final exam. It was worth it. So reward yourself for the hard work. And be honest with yourself. Be humble with others. Don't be arrogant. And give grace to yourself and to others. Vision of a future while living in the present. That Venn diagram encompasses 3: the head, the heart, and the soul. The head, strategic thinking, protocol thinking. What the heart is all about. Vision, creativity. And then the soul, conceptualizing. What's the meaning of things? Best approaches to leadership. Leadership is about relationship. To inspire people, you need to interact with people. So it's about relationship. Leadership is everyone's business. We are all leaders in this room because you're leading your own life. Leadership development is also self-development. In closing remarks, it is only, I like that quote of Antoine de Saint-Exupéry, The Little Prince. It is only with the heart that one can see rightly. What is essential is invisible to the eye. When you deliver care and you imply and you practice, you apply empathy and compassion, all of that is invisible. However, the impact of it is tremendous. Let us ensure that medical curricula integrate formal leadership training to better align skills with responsibilities and help the next generation of healthcare professionals reach at least the level 3 of the 5 level of Maxwell leadership. Somewhere, sometime, the leaders within each one of us in this room and beyond may get the call to step forward. So we have to be prepared. On that note, I would like to leave you with this. Leaders are not just born. People can be trained to become effective leaders. So let's help them. Acknowledgement, Dr. Mookambika and Sree Mookambika Institute of Medical Sciences, leadership team, Dr. Vishnu Ashok, my apology if I'm killing your names, SMIMS MedVision, Dr. Elsa, my dear friend, my Public Health Leadership and Practice Department Chair and Mentor, Dr. Vaughn Upshaw, my academic institution, the University of North Carolina, Chapel Hill, Tar Heels, the audience for actively engaging in my presentation and leadership, last but not least, my highly loving, supportive family. And namaste, shukriya, thank you, references, and the floor is open for question. And thank you, namaste. Thank you.
Thank you, madam. Thank you for the wonderful presentation. Last half an hour, we learned so much from you. So what I understood was madam's philosophy is in teamwork. Leadership and both learning and leadership is indispensable. So we'll try to include it in medical curricula for a healthy society. Thank you, madam. Please give her a big round of applause.
Thank you, ma'am. To felicitate both the resource person, Dr. Mary Lina Excellent, and the chairperson, Dr. Indu Pisharedi, I welcome Dr. Deeksha Pandey, Professor and Head of Department of Obstetrics and Gynecology. Ma'am, please.
And you are wearing my favorite color, lavender, so I feel very, very grateful.
Thank you, madams. Now we will have a session on assessment strategies in CBME, moving beyond traditional exams, by Dr. Tejendra Singh and Dr. Swaminathan. The list of delegates will be displayed on the screen now. Simultaneously, we'll have a e-poster session in the council room, ground floor, Medical College block. The list of delegates for the session Assessment Strategies in CBME, Moving Beyond Traditional Exams will be displayed on the screen now. The e-poster session will be held in the council room now, ground floor, Medical College block, the same floor. Sorry, there's a change in the venue. The e-poster session will be held in the Denundry Hall, that is in basement 2, Medical College block. Dhanvantari Hall, Medical College Block, Basement 2. The participants who are not there for the workshop now can move towards the Dhanvantari Hall. The delegates for the assessment workshop, please move forward. Others can move towards the Dhanvantari Hall for the e-poster session. Only 30 people are there for the workshop, so can you please move forward?
The participants for the workshop are Dr. Harsha HS, Dr. Shweta D. Somvanshi, Dr. Suresh MK, Dr. Beulah, Dr. Nita Hubert, Dr. Suresh PM, Dr. Sreeja Nair, Dr. Rajendran MC, Dr. Abhishek, Dr. Biju Gopal, Dr. Deepthi VD, Dr. Ashmika Nair, Dr. Jayasree, Dr. Bayaril Chitra, Dr. Vijay Sundar, Dr. Jasmine Mary Jacob, Dr. Arati Raj, Dr. Minnu Cherian, Dr. Sunita, Dr. Suhaina AS, Dr. Nirmala C, Dr. Liji Justin, Dr. Jaren S. Das, Dr. Kalai Selvi, Dr. Pabita Devi, Dr. Asim Jafar, Dr. Rakesh C, Dr. Lyra John.
Participants, please switch on to your, take your mobiles. Please load www.mentimeter in your mobiles, or take the help of the Wi-Fi from the hall. I think it's SVIMS. Passcode is 1234567889. Huh? www.mentimeter.com. Mentimeter.com. Meter.com. Just keep it ready. It will be menti.com. www.menti.com. Please keep it ready. The code will come. Okay, just keep it ready because. Just wait. The code will come. Yep. Keep it ready so that when search starts, it will be easy for you to. Just keep it ready once the code will come. No. Just wait. Caller mic is there.
So good evening, friends. Let's begin with our agenda. And we are going to go into a workshop mode. So what I request is for an active participation. And at any point of time, if you feel that I have not been able to communicate well, or if you think I should be explaining a little more on what we have said, please feel free to stop us. Because building the concept is more important than just covering the material. Now, although the topic that was given to me was about assessment strategies in CBME moving beyond traditional examinations, but I took the liberty of actually modifying this topic because I don't think that for CBME you have to have any different assessment method. So basically what we need to do is actually to look at the traditional assessment methods but with a different lens. See, after all, for assessment of knowledge you still have to have MCQs or essay questions. You can't bring something else because it's now CBME. Same happens with practical skills, same happens with so many other things. So what we are going to do today is to look at equals. We will look at the role and functions of assessment. We would look at typology of assessment. We would look at the function and the peculiarities of assessment for competency-based medical education. And then we would look at the forgotten principles of assessment, because that is where actually the problem has started. If we apply the assessment principles as it is, then a lot of problems are sorted. And then finally we will try to see what are the practical implications of all these discussions that we are going to have. On your mobiles, please log on to menti.com and use the code 12494822. Are you getting the question on your mobiles?
The code is 12494822. 12494822. 22.
So
start typing your responses.
Please start writing the responses. And we want your ideas, your responses. So don't discuss with your neighbor. Even if you are not sure of the formal definition, doesn't matter. You can still put your ideas about what assessment is.
participation. The response is anonymous, so you can type whatever you want.
Okay, so as I see at 10 responses which we have received so far, so basically what most of you have written is to see how much a student has learned, right? That is the consensus most commonly evolving, that assessment is to find out how much a student has learned. Now before I go further, I find this term evaluation used very frequently. If you see here, then evaluation. So it's coming frequently. Now one can say that there is no difference between assessment and evaluation, but to make sure that we are on the same page, let's be clear that when we talk of student test or examinations, we use the term assessment. When you say evaluation, you are talking of educational programs. So when you want to see whether your MBBS program is producing competent doctors, then what would you do? Evaluation. But if you want to see if your student has learned a competency, what would you do? Assessment. So keep that difference in mind, because otherwise it sometimes can create confusion between what exactly we are trying to see. Okay, so here are the thought process that you have, and most of it is actually related to testing and to find out what the student has learned. Okay, now let's look at the definition of assessment. Ma'am, will you please read out and go slow?
What is assessment? Assessment is the systematic collection.
Hold on. So what is the first point which comes out? That assessment is a systematic process. You know, just barging into a classroom and saying today is your test is not assessment. So assessment is a systematic process. Okay.
It's a collection.
So it involves collecting data,
review,
analyzing that, reviewing that data,
and use of information about educational programs to improve the student learning.
Now compare it with what we had written earlier. We had said we just want to find out what the student knows, whereas actually assessment is involved with what can be done to improve the student learning. So it's a basic difference. It's a very small, subtle difference, but it makes a lot of difference. You know, assessing a student only to find out what he doesn't know versus assessing a student to find out ways and means of how you can help the student to improve his or her learning. Okay, can you please?
It focuses on what students know, what they can do, and what values they have when they graduate.
So the complete focus of assessment is not on what they do not know. The focus is on what they know, what they can do, what have they learned in terms of values, attitudes, communications, and so many other things, and the collective impact on student learning. So keep these factors in mind, because whenever you plan competency-based assessment, you have to keep this in mind. The purpose of assessment in CBME is not to find out what the student doesn't know. The purpose of assessment in CBME is to help the student to become more competent. Now we all have been taught in basic course workshops and so many other places that you have formative assessment and summative assessment. In fact, the terminology has gone slight change, because that actually describes the process in a better way compared to formative and summative. So what we now classify is one, what is called assessment of learning, and and assessment of learning is equivalent to summative. The second is what is called assessment for learning, which is equivalent to formative. So summative is called assessment of learning, formative is called assessment for learning, and yet another term which is actually becoming popular and being used more and more is called assessment as learning. Because the purpose of assessment is, as we discussed earlier, not only to say pass fail, not only to say you know, you don't know, rather the purpose is to improve the process of learning. And therefore, how can you use assessment to improve learning, and that is what actually comes under assessment as learning. So I invite Dr. Swami to share.
Thank you, sir, for this wonderful opportunity. So I'd like to continue where sir left. So we already know about the various attributes of assessment, and we generally know about the prototypes of assessment. So why do we need to assess? So we already saw what is assessment, why should we assess? So we have various purposes for which we assess. Because we already know, as sir rightly highlighted, it drives learning. It can be done to find out whether we have attained the objectives are met. It gives feedback to the students to safeguard the public, particularly in finals, when we send the patient out to the community for certification and to know about the learning process. And this purpose is not standard. It varies from period to period. Before he comes for the class, the purpose is different. While doing the program, it is different. And after doing the program, it is different. And this we must have in mind. We must assess what we teach, and we must teach what we assess. This we have to be very clear in our mind. And as sir rightly said, we have these three forms of learning, and these two we know. Assessment for learning, formative, we are practicing in our day-to-day classroom. So we assess the students while taking class, we keep periodical examinations, we give feedback, we know the process. And summative, we already know we have an university, a regulatory body which carries out the exams in a specific pattern. And what is this assessment as learning? Have we done this? What is this? Self-evaluation. Just self to say, okay, I'm good. Is it assessment? Can it include something else also? Can be with the help of a peers, you can ask your peer, how did I do? Get his feedback and correct yours. So it's a sort of a way of learning. So I like to share. So this all we already know. And this assessment as learning, the main cornerstones of this is a very high quality feedback and is a continuous ongoing one. So just I'm to share you with few slides of my fellowship journey under the mentorship of T.S. sir in Adesh University, a fellowship in assessment which works under the principle of assessment as learning. So we started the journey in November 2023, the 4 fellows here, and we completed the journey in the year December 2024, the same 4 fellows with happy faces. And these are the new entrants for the batch of 2024. So this is, what is this program and how we go about this because this session I want to share the feelings as a learner who was benefited by this assessment as learning strategy. So it's a capacity building program, the whole fellowship. It was based on purely the principle of assessment as learning, which uses near peer teaching and application of knowledge in the form of a small project. So here, as rightly said by the participant, your learners are the own assessors. It uses both formal and informal feedback and a self-assessment to understand and improve. So here the methodology
It's a 12-month-old program. Here, every month we are given an assignment, which is a higher order, a task, which is based on higher order thinking skills, probably a problem-based analytical skill, and we give a reply. This reply is reviewed by your peer, who gives the feedback with the references. We correct those. We take the feedback and we correct ourselves, and we give. There's a very major role played by reflections. And here the advantage is there is no constraints of weekly mails, 2 mail a week, nothing. And we have a very friendly faculty who will handhold us. So this will be the type of assignments we get. It can be a case study in which we have to think, play the role and find out the solution, or could be a task on a learning experience, or could be a task on planning a strategy. So this could be a conglomeration of all these in one assignment. And peer feedback. Once we submit the assignment, we are tagged with a peer, and he will give a beautiful comment like this. The feedback is very nice. It will be nicely written, beautiful language. No, it will be on every paragraph, every concept you say will be critiqued by the thing, and we get both appreciation and also words for correction. Some of the peer feedback, snapshots of the peer feedback, what we got, when we got. We also write, we try to say what we know and what we don't know. And the excellent thing is the faculty feedback. Whenever we go the track, when we go off the track, or when we have a problem in understanding, the faculty come in and they give the feedback. And they not only give a feedback, they give a reference for us to go back, to read, and come back with a correct concept. As Sir said, concept building is very important. So these are some of the snapshots of the feedback which is given. So what was good about this program? It is a purely a self-directed learning built on problem-based task. For answering the task, we need to have a thorough review of literature, and answers are not just cut, copy, and paste. And the major strength, what I felt as a beneficiary, was the pure feedback and the guidance of the faculty. It imposes self-regulation, and we learn the technique of giving a feedback, receiving a feedback, modification, modifying our thought according to the feedback, getting the responses from the faculty. And the atmosphere is and very much supportive. Thank you so much. Over to Sir.
Okay. Now, since we are discussing assessment in competency-based medical education, it stands to reason that we should be on the same page about what is competency-based medical education. So can we have your thoughts on what you understand by the term competency-based medical education?
Type your responses.
basically what most of you have written is that it is a outcome-based learning process which tries to produce Indian medical graduate, and the purpose is to have a competent medical doctor. Some in fact have just expanded the term CBME to say competency-based medical education, but that essence is not coming. What is competency-based medical education? When somebody says we were taught as traditional curriculum, but now we are teaching as competency-based medical education. So what comes to your mind? What is being done now? Okay, let's look at the definition. Ma'am, can you read, please?
Competency-based education, an outcomes-based approach.
Okay, one, that it's an outcome-based approach. Some of you have written also. So you are not just looking at the student sitting and completing 50 lectures, 30 clinics, 30 weeks of this, 20 weeks of this. No, you are actually looking at what the student will be able to do at the end of the program. Okay.
To the design, implementation, assessment and evaluation of medical education programs using an organizing framework of competencies.
So that means in competency-based medical education, the basic unit is a competency, and it is the competency which is used to design, implement, assess and evaluate the total program. So that means the competency-based medical education would differ from conventional education not only in being outcome-based, but also in something which is using the framework of competencies for almost everything related to the curriculum. Okay. Now, the next logical question, then what is a competency?
Please type your responses of what is competency.
See, if we have to design a competency-based assessment, then we should be clear about what is competency-based education, and if we say competency-based education, then we should know what is a competency, because then only we will be able to design an assessment.
Type your responses, whatever comes to your mind. Very commonly used term now.
In fact, the responses have brought out some different terms which are otherwise different but look almost similar. For example, ability, and then comes skill, and then comes competency. So it would be confusing unless we know the difference between skill and competency. So the definition of competency is?
Competency refers to a healthcare professional's ability to effectively integrate knowledge, skills, attitudes and values in clinical setting to provide safe and effective patient care.
Can you say it in your own words? Forget what is written on the screen. So what is a competency?
Competency of a doctor to perform an activity which will be done by an equal person.
Some key factors are there?
To integrate knowledge,
So
skill.
competency is a combination of knowledge, skills,
attitudes, and values.
And performed in a clinical setting and is useful for effective patient care. Now, ability is something different. Skill is something different. Competency is a combination of knowledge, skills, attitudes, values, clinical setting, and benefit to the patient. So if you have to assess competency, you will not simply assess knowledge. You will not simply assess a skill. So what you have to assess? A combination of knowledge, skills, attitudes, values, etc., etc. So it brings us to how does a competency differ from skill?
Please opine. How does a competency differ from a skill? Are both synonymous?
So out of the responses that I have got, in fact, two catch my attention. One, that the skill as an ability to perform need not have knowledge and attitudes for the same. Take for example, your OT technician. He can perform lot of things, but without knowing what he is doing. He cannot explain why he gave this much oxygen or why he is giving this pressure while ventilating. He probably cannot explain. Look at your dialysis technician. He can do lot of things, more things than a doctor can do. But without actually knowing the rationale, the basis, the theory and other things behind it. Second is what becomes important here is that competency is a combination of knowledge, skills, attitudes and values, and skill is only a part of the competency. Now, what I am trying to say is that most of the times whenever we talk of CBME, what comes to our mind is skill. You know, we talk of skill labs, we talk of skill acquisition, we talk of logbooks to document skills and so on and so on. But skill is not synonymous with competency. Competency requires something more than skill. Here is an example. What is ability? Ability is having the required attributes to perform something. Let's take the example of passing a nasogastric tube. Now, if a student knows the anatomy, he knows the physiology, he has good coordination with his hands, he has good vision, so he has the ability to pass a nasogastric tube. That is ability. It does not mean that he will necessarily be able to do it. He has all the requisites for doing that. When you say skill, the student is able to insert a nasogastric tube into a mannequin. That becomes a skill. It's not competency. It remains a skill. When a student is able to insert a nasogastric tube in a crying child brought to the emergency department for ingestion of some poison and take history from the parents, what is he demonstrating? Competency. Remember the definition of competency? Performed in the clinical setting for the benefit of the patient. So when you have to assess for competencies, assessing in the skill lab doesn't serve the purpose. You have to assess somewhere with the clinical background. And once you have acquired multiple competencies, you are called competent. So would you remember this distinction? Ability means having the required attributes. Skill means doing something after learning. Competency, when you integrate knowledge, skills, attitudes, communication, values, etc. And competence, when you have collected multiple competencies so that you are called competent. So when we say Indian medical graduate is competent, what are we implying? All, or maybe he has acquired multiple competencies related to the task. You know, it's not that one competency of heart and one of lungs and one of brain, that will not make him competent. So related competencies, and that means not only the skills but also the knowledge, values, communication and the benefit to the patient. Now coming to competency based assessment. We discussed earlier that the purpose of assessment is not only to find the shortcomings of the student. For competency based education, this actually becomes even more important. So the purpose of assessment for CBME is to support the development of competence. So it has to tell you where the student is, and then you have to go back to the definition of assessment. You have to collect data, you have to analyze that data, and then you have to use that information for better learning of the student. So assessment tells you where the student is, you analyze what are the issues, what are the problems, and then use corrective actions, most commonly feedback or repeat performances, so that his competency acquisition becomes better. And what is more important here is that you should be assessing around content, not around domains. What does it mean? That if you are assessing a competency related to, say, lungs, and you are doing a pulmonary function test, asking the student to demonstrate a pulmonary function test, then also assess the theory related to pulmonary function test. Also assess the communication related to pulmonary function test. Do not do like this, that I will do pulmonary function test and I will do ECG and I will do EEG, because all are practical. That doesn't serve the purpose. What serves the purpose? You have the skill, related to that skill you assess the theory, related to that theory you assess the attitudes, values and communication. Now this is a very old saying, I would say. In fact, 1976 was the year when WHO first introduced competency based medical education. And around the same time, it was stated that the effort in competency-based education is not about developing a new teaching methodology. So there is no specific teaching methodology for CBME. What is specific? It is the design of valid assessments. So if you have to change one thing to successfully implement CBME, what would you change? Assessment. Unfortunately, we have gone the other way around. You know, we changed everything else except the assessment. But anyway, these are the efforts that we have to make and convince everybody around that it is the assessment, valid assessments, which are crucial for success of competency-based medical education, rather than changing the timetable and integration and self-directed learning and so on and so on. They are not going to result in a competent graduate. So the next question, what is validity in assessment? And keep the previous slide in mind that what you need to develop are valid assessments. So naturally we have to answer the question, what is a valid assessment? What is validity in assessment? This is the most common definition which we have learned. Basic course workshops, you know, that's what they teach us. What is validity? Validity means measuring what it is supposed to measure. But actually there is a problem with this. You have a weighing scale to weigh truck. You know, on the highways they have a weighing scale to weigh the truck. And you have a gold bangle. Can you weigh that bangle on that weighing scale? You cannot. So this definition doesn't really work in student assessment. What is that weighing scale supposed to do? Supposed to measure weight. But can we measure a bangle? No. So it is not that a tool is valid or invalid. That is the point I want to drill in, that it is not the tool which is valid or invalid. It is the inference that you make which is valid or not valid. So basically validity is the inference that you make from assessment data based on theoretical reasoning and empirical evidence. So what is the implication? Don't be tied with a tool. Don't say we are using OSCE or OSPI, so our assessments are valid. That is not true. What is true? is the interpretation that you make out of the assessment. So if you give an OSCE and then you say this student is fit to be a clinician, is that all right? That is what will be validity. So don't be after the tool, be after the inference that you draw from that tool. What factors you think would lower the validity? You have rightly written some of the very common causes of low validity. You know, if you want to measure weight and you use a thermometer, then obviously that will not be a valid kind of assessment. Same way, biases, yes, they can hamper the validity. Then too many assessments, too little assessments, they can again hamper the validity. Poorly written questions. You want to ask about a triangle, but your question gives the idea of a square. So obviously the student is going to write a wrong thing. So that can hamper the validity evidence. But if I have to classify all these into two categories, what I would say, one is construct irrelevance and second is what is called construct underrepresentation. What construct irrelevance means is commonly stated, for example, when you start giving marks on the basis of handwriting rather than on the basis of what the student has written. So there is construct irrelevance. When in the viva or in the practical examination you start giving marks based on the gender of the student rather than the answers that you receive. So that becomes construct irrelevance. And construct underrepresentation is then when there can be 50 questions related to a topic, but you ask only 5. So when there is no blueprinting, when you have not decided how many questions from each topic should come, then some topics will be totally left out. And this is a common problem with our situation. We assess theory, we assess skills, but we leave out professionalism, we leave out communication, we leave out ethics, we leave out so many other things, sympathy, empathy. Nothing is assessed in our kind of system because of subjectivity problem. Now that's a big chunk of what is called construct underrepresentation. And so remember, the two factors which would contribute to low validity would include construct irrelevance and construct underrepresentation. The other parameter related to validity is reliability. So which of these you think best defines reliability? see this reproducibility of the results and same result under same condition. These are the common definitions of reliability that we have learned and which we often use to explain the thing. But suppose you go for an examination and two examiners sit and decide that we are going to give 6 to every student. Will be reproducible, will be consistent, but we are not reliable. Reliability is when you say that a student is fit to become a doctor and you are willing to have yourself treated from that student. That is reliability. I am reminded of a story, Dr. Venu Gopal, the first cardiac transplant surgeon of India, who was director of All India Institute of Medical Sciences, New Delhi. He needed to have a coronary bypass surgery. He could have called any cardiac surgeon in the country and he would have been happy to come and operate on him. But he insisted that his student should operate on him. That is reliability. Yesterday I asked this question, how many of you are willing to get operated by your own student? Not a single hand went up. And what do you think would have been the reasons for Dr. Venu Gopal to have that faith on his student? So did he look at his NEET score? Did he look at his gold medals? Did he look at his MBBS marks and publications? No. So what did he look at? The work. And it didn't happen in one day. You know, it was the result of a long ongoing process. Something similar happens when we assess students. You know, on one day, saying this student should get 8 marks and this get 5 marks is no assessment of the student's ability. You have to observe the student for a longitudinal period of time. And with internal assessment and formative assessment being available to us, which are not part of the final total, this gives us a very good opportunity to in fact assess the student over a long period of time. In my workshops, actually tell the participants to read reliability like this. Reliability. Can you rely on the results? When you say this student is fit to be a doctor, are you comfortable saying that? That is reliability. Now having 0.8 and 0.9 and any index or any figure, that doesn't really help us. And again, please remember, like validity, reliability is not linked to a tool. Reliability is about the inference that you draw from the results. So the second carry home for you today is that it is not the tool which is valid or invalid or reliable and unreliable. It is the inference that you draw from that tool which is valid and reliable. So keep that in mind, because then what will happen is you will not keep on focusing only on MCQ and ASCII. You will go for many other things. And like validity, what can lower the reliability? ask anyone, even at times I would be tempted to say that the most common cause of low reliability is the examiner bias. Right? Everyone would say that number one cause of low reliability is examiner bias. But unfortunately, that is not the cause of low reliability. Let's look at some of the causes of what can cause low reliability. One, that when the sample is unrepresentative. You want to test the knowledge of CNS, but your questions relate to CVS. So that is a problem which causes low reliability. Second, too small a sample. If you draw a graph, the reliability increases with the sample size, and you require minimum of 200 MCQs to reach an acceptable level of reliability. In our settings, how many MCQs we use? 20. That's nowhere close to what will give you a reliable results. Now, I hope you are able to notice that difference. What we are working on, MCQ is reliable. But actually what is happening is, the interpretation that you are drawing out of that is unreliable. So, and I'm not saying you give all 200 at one go. You can divide it over a period of time. So every month, for example, if you give 20 questions, so by the end of the year you would have given them 200 questions. So that will give you sufficient reliability. Then too easy and too difficult questions. You know, it's just like you've seen that airport scanner. So when you pass through it, and if you carry a metal object, it sounds a beep. Now suppose the scanner sounds a beep irrespective of whether you carry a metal or don't carry a metal, or conversely, it doesn't sound a beep even when you are carrying a metal. So will you depend on that beep? No. Same thing happens with too easy and too difficult questions. So when you do item analysis, so your question should be answerable by at least 50% of the students. If more than 70% are answering, there is a problem. If less than 30% are answering, there is a problem. You need to modify the question. And the most important cause of unreliability is content specificity. In the examination, you give a case which the student is unlikely to see again in his life. Especially for PG examinations, you know, you will find a very complicated CNS case, hoping that if he can do this complicated case, then he can do everything. But which is not true. Doing a CNS case does not mean that he can do a pain in abdomen or a upper respiratory tract infection also well. So, have a good representative sample, and that is what I mean when I say that when your sample is unrepresentative, your results are going to be unreliable. And especially when you are doing performance assessment, you know, theory still it is a manageable part, but when you are doing practicals, when you are doing clinicals, then you have a problem. And the problem is not only that there is a variation between the students, but also there is a lot of context involved. I remember I had gone to give DNB exam. I was in Ludhiana, my center was in Mumbai. I got a patient of rheumatic heart disease. Patient or his father didn't know any language except Marathi. I never knew Marathi. So they provided an interpreter who was probably translating wrongly for me. And in the end, I prepared a history based on what I was told, but in front of the examiner, he changed his version. No, I never said this, I meant this, I meant this, I meant this. So this context becomes very important. And you have to be careful that if your context changes, your assessment results will change. Also, you are simultaneously assessing multiple tasks. Take for example, you are assessing a student on how to record blood pressure. One simple straightforward is the technical part, how much he inflated, how many sounds he heard, etc., etc. But there are a whole lot of other things. How is he dealing with the patient? How is he consoling the patient? Is he gentle with the patient? Did he make sure that there is rest between two attempts? And so these are multiple things which come into it. And even though he may have given you a correct reading, but because of many other things, your marks which you give may be less. So this context makes a lot of difference. Just look at this table. What does it tell you? I'll elaborate. This is multiple choice question. This is patient management problem. OSCE, you know. This is mini clinical evaluation exercise. And these are the reliability figures. So what does it tell you? Interpret this table. Let's focus only on two columns, long case and OSCE. Which is more reliable? But according to us, what should be more reliable? OSCE. Look on this side, MCQs and essays, which is more reliable? But according to us, which should be more reliable? MCQs. But here you are getting exactly the opposite results. See, OSCE is giving a reliability of only 0.47 contrasted to a long case presentation which is giving you reliability of 0.6. Okay, let's add more to it. Now, so as your testing time increases, your reliability increases. And if you have 8 hours testing time, then you will find that the reliability is almost similar for all methods. So there is nothing to choose between OSCE or long case or MCQ and essay. What you have to choose between? The duration. So it is the testing time which decides whether your assessment is reliable or not reliable. Now, OSCE is highly objective, long case is subjective. So can subjective assessments be reliable? Can subjective be reliable? I think no will overtake yes, the way it is going. Yeah, 8, one more and you will be equal. Could somebody who said yes just explain in one line why you say it is reliable? Doesn't matter. Even if it is wrong, doesn't matter. Somebody who said yes, please explain it. Anyone? There are 9 people who who said yes. Ma'am? Okay, explain no. Tell why no.
It's only a subjective assessment, sir. There's no definitive how to measure the assessment. I mean, that's why
Okay.
it
Somebody,
varies from
somebody who
person
said
to
yes. Huh?
Sir, I said yes because maybe some problem-based thing, or when we give scenario, they may come up with same solutions again and again when that is the right solution. So I said yes.
Yeah. See, what happens is that many of the problems in medicine do not have a simple, straightforward answer. There can be more than one answer. Which antibiotic will you use for staph pneumonia? It's not that you have to name only one. There are multiple antibiotics you can name. So when there are more than one correct answers, then subjective decisions matter a lot. One examiner may say A, another examiner may say B, another may say C. It's not that one is right or the other is wrong, as long as you can justify your choice. And as we looked at the previous slides, I mean, if you look at the previous slide, it is not the examiner bias which is a cause of unreliability. What is the cause of examiner bias? The content specificity. In our system, for example, one student gets a CNS case, one gets a lung case, one gets an abdominal case. That is the cause of unreliability. Not everybody will get a CNS. You cannot have so many cases. How will you give 100 CNS cases? You cannot do that. So there is pick and choose. So that is what actually causes unreliability. And come to think of it, even MCQs, which are the prototype of objectivity, also undergo lot of human intervention. If I ask all of you to write questions on toxic effects of anti-tubercular drugs, say that is your competency. If the student knows toxic effects of anti-tubercular drugs, which drug will you choose? See, again subjectivity, na? So he will say ethambutol, he will say parazenamide, but natural, nothing wrong in it. So what? Chalo, let's try to circumvent that. We'll say no, don't do like this. Let's do on rifampicin. What will you ask? Again unreliability. Again a subjectivity. Both are right. Both are side effects of it. So if you look at MCQs, even there nothing is objective. It all depends on the mindset of the examiner. If they were so objective, then all entrance examinations in the country should have had similar paper. And the students should have had similar ranking in all the examinations. But it doesn't happen. You know, somebody gets selected in All India Institute, but the same student fails in the state. Now, of course, the NEET is there, but earlier this used to be very common. They'll get selected in one place, fail in another place. Why does this happen? Because subjective. One can say we have a computer selected question paper, but please remember that computer will also select according to the thought process of the person who has programmed it. So even that doesn't remain objective. The point which I want to emphasize here, the third carry home for you, don't feel shy of subjectivity. More so when you look at the definition of competency, knowledge, okay, you can do objectively. Skill, to a certain extent, yes, but values, attitudes, you cannot objectively assess. You have to subjectively. So if you want to assess them, you have to use subjective judgments. So don't feel shy of that. And moreover, they are not added to the final total, so it doesn't matter. See, ultimately the purpose is that you have to convey to the student that it is important to learn communication. It's important to learn attitudes, and that can be conveyed only when you assess these things. If you drop these things, oh no, they are subjective, we won't assess. Then students will also get a message, these are not important, why should we learn these things? So please keep that in mind. So ultimately, where we are, one, that no tool is inherently valid or invalid. Also remember that no tool crosses the level of mirror's pyramid. So you cannot have one tool which will assess all 4 levels of mirror. So you have to have a different tool for nose, you have to have different for nose how, different for shows and different for does. Each tool has strengths and weaknesses. And so the concept of assessment toolbox is actually coming. So it's not just one single tool that you have to use, but you have to use multiple tools. And this is the last thing I want to show you. This is the concept of utility of assessment. Basically, utility of assessment is a multiplication of validity, reliability, feasibility, acceptability, and educational impact. Validity, reliability, feasibility, acceptability, and educational impact. Now, if you look at tool 1, it has certain values, so the figure comes as 8. Look at tool 2, the values are different. It is not, for example, that much feasible, but it has got a high educational impact. The value is still the same. Another tool where validity is relatively low, reliability is also low, but acceptability and educational impact is very high. So the utility becomes much more than the other tools. And imagine a tool which actually prompts the students to learn medicine from MCQ books rather than textbooks, the utility will be 0. So, open for you. Any questions, any comments, anything which you want us to clarify? If you have to go home with 3 points, just remember that competency assessment is not only about skills. That is the first thing. It has to involve other things associated with a competency. Second, subjective assessments can be as reliable as objective assessments. And third, that validity and reliability are not linked to the tool. They are linked to the inferences or interpretations that you draw out of those tools. So thank you very much. Enjoy the day.
I request the delegates to please stay back. Tea will be served and we'll be joined by other resource persons and delegates in a short while. Kindly fill day 2 feedback forms which are available in the WhatsApp group. Kindly stay back. We are joined by other resource persons and delegates. Kindly fill day 2 feedback forms which are available in the WhatsApp group. The valedictory function is going to start. Please settle down. Someone's phone is here. Someone missed their phone.
Requesting Dr. Thomas Chako sir to come onto the stage for distributing and declaring the prize winners for our e-poster competition. Okay, so we'll start with the third prize, which is for the topic Most Impactful Teaching Strategy. Prize winners, Dr. Supriya Selvakumar and Dr. Lisha Vincent. Requesting the third prize winners, Dr. Supriya Selvakumar and Dr. Lisha Vincent. Second prize for the poster titled Student Centered Teaching Excellence Second prize goes to Dr. Deepthi VD. First prize, Best Innovation in Medical Education for Dr. Susie Joseph. Ma'am is from Trivandrum Medical College, Dr. Susie Joseph. Thank you, sis. We're coming to the closing ceremony, before which we request if one of the delegates could come forward for giving us a feedback on and your thoughts and reflections about the whole program.
Good evening to all my respected faculty, dear delegates and all the participants. It was indeed a very pleasurable learning experience to be with you for these 2 days, and a remarkable hospitality, food, and even academics. It was, we were awake throughout, and the most important thing was all the distinguished and respected faculties, which we always listen to them in the YouTube videos, and even Dr. Tejinder Singh, pediatrics, because ourselves, I am in pediatrics, so we regularly read your articles, sir, in Indian pediatrics. And it was awesome, all the talks by all the experts. And the most important thing, the thing was about the assessment in CBME, sir. Still, I think, as sir has told, assessment is a king. And I think we are not in the track to a proper assessment strategies. So a uniform assessment strategies, if it would have been improvised in all the medical colleges, that would have been better, because as you all know, assessment drives learning. So it is our assessment strategy which could be improving our CBME. And thanks a lot to all of you. Thank you.
Can I request Dr. Nirmala ma'am, Professor OPG, to give her feedback?
Thank you. Actually, these 2 days of, initially, let me thank, I don't know how to appreciate and thank Mookambika ma'am for such an innovative training program on 2 days for all the faculty of this, Mookambika institution and also outside. It's an excellent opportunity for, at this age, I feel it's fortunate to learn all these things. It's a part of continuous learning, which this aspect of medical teachers training I've never had anywhere. I have almost 37 years of teaching experience. So first time as a teacher I'm learning more scientific aspects of a competency-based. Traditional medical education, of course, we never had any training. Competency medical education, I really had some trainings before, but this is a very innovative type of training where everyone is made to participate, everyone is made to make some critical thinking. And on my way back yesterday, I was telling Suresh, sir, oh, we are fortunate to work with Dr. Mookambika. Thank you so much. And the youngsters, you're so lucky to get so much from this, which you can carry forward so that you can improve the students and improve. So in the long time, this way you can contribute to the welfare of the society. And thank you. And all the faculty, thank you so much. You took so much pain to put us, because I have a very bad habit of sleeping in the afternoon. But yesterday and today, I never slept. Okay, thanks you all again. And food, hospitality, arrangement, in par with any. I've attended many international conferences many times. All arrangements in part, I think you will agree with me, right? In par with the international standards. And everything is so good. Thank you so much. God bless you.
Thank you so much, ma'am. As we bring day 2 of MedVision 2025 to a close, we have witnessed another day full of insightful discussions, innovative ideas, and meaningful exchanges. Today's session have been a testament to the power of collaboration and commitment we all share to advancing medical education. Now, to deliver the valedictory and the vote of thanks, I invite Dr. Indu Pisharedi, our MU coordinator.
A very good evening to the esteemed faculty members, colleagues, and honored guests. It's both a privilege and a profound honor to stand before you today as we reflect on the journey we have taken through this insightful and enriching conference on the future of medicine, and how we as the building blocks are mandated to shape it. Over the last 2 days, we deliberated on the evolving landscape of medical education that demands not only academic excellence, but a transformation in how we train and value the next generation physicians. The future of medicine will not be defined by the technological advancements or clinical precision. It will be shaped by the depth of our compassion, the clarity of our communication skills, and the strength of our leadership qualities. These are not just supplementary skills. They are the core competencies in a world where patient seeks not only cure, but care. I thank God Almighty for the culmination of this event in an exemplary manner. In the same breath, I like to extend my thanks and gratitude to our Chairman Sir Dr. C.K. Velayudan Nair and our Director Madam Dr. Rema V. Nair, who have been the pillar of strength and support and guiding light for providing impetus for shaping the future of medical education. The indefatigable efforts of Dr. Mookambika Madam, Vice Principal and Organizing Chairperson, is evident in each element of this conference, be it in a support role, advisory role, or as a colleague to many. Thank you, Madam, for your omnipresent involvement for the betterment of medical education. I would like to extend my gratitude to Dr. Vinu Gopinath, the Deputy Medical Superintendent and Advisory Board Chairperson, who rendered unconditional support for the conduct of this event. A special thanks to our Administrative Officer, Prasad Sir, whose wholehearted cooperation and tireless effort helped us to organize the event successfully. The organizing President, our Dean, Dr. S.M. Kannan Sir, whose effort is evident in the planning and execution, which has fructified into an event of such magnitude. Thank you, sir, for your constant guidance. I extend my thanks and heartfelt gratitude to each of our esteemed speakers for sharing their valuable knowledge, experiences, and research insights with us. Your expertise has greatly enhanced our understanding and will surely guide our future practices. Thank you for taking time from your busy schedule and providing us with your valuable lectures and workshops. I thank all the delegates from other colleges who attended the conference. Without your presence, the event would not have been successful. I extend my thanks to the HODs of different departments, senior and junior faculty members who believe in the future of medical education and ensured their constant support. And thank all the faculty participants of our college for their enthusiasm in learning and also to the participants of poster competition and debate. I extend my thanks to the organizing team and the MEU members, Dr. Vishnu, Dr. Deepthi, Dr. Sajeesh, Dr. Vaishak, who have been a constant inspiration and were working diligently. I also extend my gratitude for the workshop coordinators and each and other member of our team, and to the beautiful anchors for their constant support. We are also grateful for the generous support and collaboration of Dr. Sherin, Mr. Nishant, Mr. Deepu and his IT team, technical team, and the canteen and the staff of Trayambika Vidya Mandir for their prompt catering services. As I conclude, let's not forget to thank the entire staff of this institution who have contributed in the way they were tasked and have produced results par excellence. Let us remain connected across time zones and cultures, united by our shared mission, that is, to educate, to heal, and to advance medicine to all. On behalf of the whole medical education unit, I thank each and everyone present here. Thank you.
Thank you so much, ma'am. Have a wonderful evening. Finally, we please rise for the national anthem.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय